Assalamu alaikum wa rahmatullahi wa barakatuh. It's with tremendous pleasure to welcome you all to the first annual Dermatology for Non-dermatology course. My name is Abdulaziz Medani. I'm an assistant professor in the Department of Dermatology at King Saud University in Riyadh, Saudi Arabia. I'd like to start by thanking you all for joining us today. We were pleasantly surprised by the huge number of registrations over the past week. And on that note, I would just like to mention that for anybody who registered and was unable to access the conference through Zoom, there will be a link posted on the Saudi Society of Dermatology official website, ssdds.org, and on the Saudi Society of Dermatology official Twitter page, where you'll be able to access the conference through a live YouTube stream. But make sure you access the Saudi Society website first to be able to register, put in your information to be eligible to receive CME hours. The organizing committee, led by myself, Dr. Lu'ay Salah, Dr. Lama Tawil, decided to launch this first of its kind event that will help connect many specialties in the field of medicine. Over the next 2 days, you'll be hearing different talks from a great group of speakers. And the aim of these talks will be to help physicians from various specialties in the field of medicine, such as internal medicine, family medicine, pediatrics, OBGYN, and emergency medicine, with the ultimate goal of improving patient care. Now, I would like to take this opportunity to thank the Saudi Society of Dermatology, led by its president, Dr. Sami Suwaidan, for giving us all the support needed to put together this event. I would also like to thank Lilly Company for sponsoring our event, and for Infotech for helping us launch this event as well. Now, before we begin, I would just like to pass the mic to the president of the Saudi Society of Dermatology, Dr. Sami Suwaidan, for a few welcoming words. Please, Dr. Sami.
Thank you, Dr. Abdulaziz. Assalamu alaikum. On behalf of the Saudi Society of Dermatology and Dermatologic Surgery, I would like to welcome you on the first annual course, Dermatology for Non-dermatologists. As you know, the relationship between dermatology and other medical specialties is very strong, and there are many conditions and diseases shared by dermatology and other specialties. And the main trigger for this course or activity is the big demand by our colleagues in other specialties requesting for a kind of a course or a workshop to define the needed knowledge for them in dermatology, deciding about the initial treatment plan, and also the guidance or the guidelines for referral to dermatology. So we thought as dermatologists and also as a society specializing in dermatology, we have a big responsibility towards this kind of request. And this was a major trigger for this activity, and we are hoping we will be able to meet these needs. In this particular opportunity, I would like to thank the organizing committee, Dr. Abdulaziz Medani, Dr. Lu'ay Salah, and Dr. Lama Tawil for their extraordinary work to accomplish this course in a very short time. Also to come up with this excellent scientific program. Also, I'm very grateful for our valuable speakers who are highly qualified dermatologists, and they will deliver their talks tailored to the needs of this course and to our colleagues in other subspecialties and specialties. Also, big thank you for the attendees for your time and participation. To be honest with you, we're just shocked by this huge number of participants, and we apologize for any inconvenience. And I think the organizing committee, they did their work now to compensate and to allow the chance to everyone to attend this course and get the benefit of it. So again, this course going to be for years, inshallah, and we will do our best with the organizing committee to enhance it more and more with time. Again, on behalf of the Saudi Society of Dermatology and Dermatologic Surgery, Thank you for all the organizers, the speakers, and also the attendees for their time. And I hope this course will be informative and very beneficial to you. Please accept my regards, and I look forward to see you next year. Best wishes. All the luck.
Thank you very much, Dr. Sami Swaydan. So let us go ahead and dive right in and kick off this very exciting course with our first speaker. So it gives me great pleasure to introduce to you Dr. Badr Zammo, Assistant Professor in the Department of Dermatology at King Abdulaziz University in Jeddah, Saudi Arabia. I just wanted to let you know before we do that, that if you have any questions in terms of this lecture or any upcoming lecture, please make sure to post your questions in the Q&A box that you see below. And we'll try to accommodate and answer as many questions as possible at the end of each lecture. Dr. Badr Zammo, the virtual stage is yours.
All right. Assalamu alaikum wa rahmatullahi wa barakatuh, and welcome to everybody. Let me just give me a second to upload my slides. All right. So so we're starting ahead of schedule, and this is really good. So it gives me extra time to go through my lecture on morphology. So what is morphology? Okay, we're going to talk about what is it really, the morphology. It's the beauty of dermatology, and it's the way we operate, the way we describe lesions and look at them to be able to reach our diagnosis. As you know, we do a lot of clinical diagnosis in dermatology. So that's why we focus on the very tiny little details of our skin examination. And there are many components that we're going to talk about. So what is morphology? Basically, it's the native language, the terminology we use to describe different skin lesions, irrespective of what is the underlying etiology or pathophysiology. So basically what we see with our eyes. And this has a primary key in establishing diagnosis or narrowing down the differential diagnosis, and for documentation of progression over time, and also for communication with other dermatologists, pathologists, or with other services as well. So this is a fun talk about our specialty. Now, morphology has two components. First, you inspect and palpate the lesions, and then you apply the correct description. So let's do a quick game. If you were to guess what animal is that, I'm sure you will be able to tell that's a rabbit. What about this? That's a bird. What about this? So in a split of a second, I'm sure you were able to tell that this was a lion. Okay. Now, how were you able to do this? Because as a child, initially you weren't able to recognize the specific features of each animal, but you were taught with time to be able to recognize the specific features of each. Now, what about this? Okay, that was too quick. But for a dermatologist, maybe that's actually a spot diagnosis of Psoriasis rosea. We see the herald patch with the trailing scale around and the Christmas tree pattern of this papillosquamous eruption. Okay, but how we reach this is with eyes training and with description. So whenever you're facing lesions or rash that you're not able to diagnose, then we go back to our basics and describing the primary and secondary lesions and other steps of morphology. So this is not a specific animal, or a primary, but once I add this, let's say primary lesion, then you can be able to identify which animal is this. Now, is this a horse or a donkey? What if I add this pattern to it? It's neither, it's actually a zebra. So a pattern of the rash can also give you a clue to the diagnosis. What if I add a pattern with a color? Okay, then this is obviously a giraffe. So if we look at this non-specific scaly, red papules and plaques of stasis dermatitis, and then here we have a certain pattern. Okay, that's like a dried river bed. That's characteristic of eczema crackly. What if I add a color and a pattern? Then those thick brown plates of ichthyosis. So what is the difference between primary and secondary lesion? Primary lesions are the characteristic or the most characteristic native nature of the underlying disease. And secondary lesions are modified primary lesions, either due to evolution of time or due to exogenous factors, as we can see here. So this is acne with the inflammation resulting in scars. Sometimes we don't have any primary lesions, but the secondary lesions that we can see give us clues to what were the primary lesions that were there before and now disappeared. So we're kind of investigating what we're seeing. And of course, there is the typical elephant, the African, and there are some other variants that are less common, but we as dermatologists, we can recognize. And there are the unusual, weird cases that needs further investigation. An example of this is psoriasis. We have the typical extensor plaque type psoriasis. We have other variants such as the inverse, the pustular, and then some weird or unusual masquerading cases of psoriasis. So if I ask you to describe this presentation here, how can we go about this? There are 5 main steps of describing skin lesions: primary, secondary lesions, then describing the color, the shape, the configuration and arrangement, and the distribution of the lesion. Okay, so what are the primary and secondary lesions? Let's start with the primary. First, the macule. Macule is basically a flat lesion that if you were to close the lights or close your close your eyes and palpate, it's not palpable. You need your eyes to see that there is a color change and there is a macule or a patch. When it's less than a centimeter, it's called a macule, and it can be hyperpigmented, hypopigmented, or any color. A patch is the same description, but it's more than a centimeter, okay? Such as in vitiligo over the elbows or the nevus simplex in pink or red color. So both are flat, not palpable, different in size, less than a centimeter or more than a centimeter. Now we have palpable lesions. So if you have an elevated, circumscribed lesion that is palpable and solid, so it's not filled with fluid and it's less than a centimeter in diameter, then this is a papule, and may or may not have any secondary changes. Now, here we can see some examples, either brown or red or any other color. Okay, so these are papules. What if they're larger than a centimeter, thicker plaques like psoriasis? So if it's elevated, circumscribed, larger than a centimeter in diameter, we call it a plaque. And as you can see here, it could be papulosquamous or it could be a vascular lesion. So we don't care about the pathology or the etiology. We are describing what we can see as in morphology, okay? So the primary lesion is a plaque. Now, a nodule have different definitions, okay, in different sources, but generally regarded as an elevated circumscribed lesion, sort of in between a papule and a plaque. So it's about 1 to 2 centimeter and usually deeper in pathology. But the depth is hard to appreciate unless you're a dermatologist or you're more familiar with the pathologies of nodules. But basically, they're deeper in pathology and usually between 1 to 2 centimeters, sort of in between a papule and a plaque. So as we can see here, those are all elevated lesions, sort of related by different sizes. Now, a tumor, we're all familiar with that. It's larger than a nodule that can be exophytic or endophytic and can be described as verrucous, as obviously here, a squamous cell carcinoma or a Merkel cell carcinoma. Okay, a wheal is sort of a special form of a plaque or a papule. So it's elevated, but it's due to histamine release, the wheal and flare response, okay, due to histamine release. So usually can be skin colored or reddish or pale with surrounding erythema. And those usually last from a few minutes to less than 24 hours, unless in some cases can last longer. Now, if it's like a papule, it's elevated, circumscribed, palpable, but it's less than a centimeter and it's filled with fluid, then it's either a vesicle, a blister, or a pustule. If it has a clear fluid, So serous, seroinguinous, or sometimes hemorrhagic even, it's called vesicle when it's less than a centimeter, such as herpes or sometimes hand eczema, the Pomflex or dyshydrotic eczema. If it's larger than a centimeter, then it's a blister. Okay, and again, it can be serous, can be clear, but it's not opaque, it's not pussy, it's not purulent, such as the prototype is the bullous bimphigoid, where you have these tense blisters. Now for pustules, as I said, if it's a papule, if it's a vesicle, but the fluid is not a clear fluid, it's turbid fluid, it has a purulent discharge or purulent content, then it's representing white blood cells, okay, or white blood neutrophils. So this is a pustule. And an example of this, such as in folliculitis, that can be infectious or non-infectious, such as in sterile inflammatory pustules of pustular psoriasis. So those are sort of related by size and content. So less than a centimeter, clear, non-pussy fluid, then it's a vesicle, or if it's purulent material, then it's a pustule, and if it's larger than a vesicle, it's a bullae. Now, those are the primary lesions. So what secondary lesions that can occur? Now, first is the crust. Crust is basically dried fluid, either serum, blood, or pus on the surface of the skin or the lesion. The prototype or the classic example is the honey-colored crust of impetigo or Staph aureus, and aureus means gold colored. Okay, so this is the classic description. And also any fluid, such as on the right here, that we see the blisters after they rupture and the serous fluid dries up, it forms a crust. So these are telltale signs that can tell us that there were an exudative lesion or an oozy eczema or a blister that ruptured. Okay. Now, what if we lose part of the tissue? What if we lose part of the tissue? If it's only a superficial part, okay, we have partial loss of the epidermis only, then this is an erosion, okay? But like in Pemphigus vulgaris, so we have a blister that ruptured and we have a very superficial lesion or very superficial erosion under or tinea pedis. Now, if the loss of tissue is deeper, going deeper into the dermis, okay, then we call it an ulcer. And it can even go further than the dermis, reaching down to the muscle and the bone, like in diabetic ulcers, in venous ulcers, or inflammatory pyoderma gangrenosum. Okay, so usually the distinction is because erosions usually heal with reepithelialization without scar formation, but ulcers typically heal with scarring. Now, fissures is a special type of deep, linear, so like cracks in the skin, loss of tissue, and they're often painful and deep, okay, as we can see in eczema and in heel fissures. So those are all those lesions represent loss of tissue in different types. Excoriations basically means excoriation or scratch marks, okay? So any itchy condition or any external manipulation can result in injury to the papule or to the epidermis, resulting in those excoriation or scratch marks. And as you can see here, they're usually arranged in a line, so representing the hand motion while we're scratching, okay, and can be deep to form neurotic excoriations. Atrophy is basically thinning. Instead of loss of the tissue, it's a different form, but this is thinning of the tissue, and it can be epidermal or dermal, or even in the subcutaneous fat, okay? And the classic example is the steroid-induced atrophy, where you have thin, cigarette paper-like, thin, hypopigmented skin, and with telangiectasias and thin skin, or some disorders such as atrophoderma, and we can see the visible structures under the skin because of the thinning of the epidermis. Now, another one is scales or scaling, okay, representing hyperkeratosis, which is basically accumulation of skin cells or stratum corneal cells that are either accelerated in proliferation, so they're reaching the top layer without proper differentiation, so their accumulation, or they're not disquamated in a timely manner. And we can see here the proto-example psoriasis and also pityriasis rosea. So each scale have different characteristics also that can help us in reaching our diagnoses. Lichenification is another secondary lesion that can be as a result of rubbing or scratching or external injury to the skin, and basically represents thickening of the skin and with accentuated skin markings, as we can see here, as a result of chronic scratching or rubbing. Scars, they can be classified as either normal, elevated, or depressed. If they are depressed like this on the right side, it's called atrophic, and we can see the atrophy of the skin and the depression of the scar, or they can be just basically replacement by fibrous tissue and normal scar. Elevated can be hypertrophic, that is maintained or limited to the site of injury, or growing beyond the borders of the original insult, such as in keloids. A special form of scars are in the acne. They're both also elevated and depressed, but the depressed ones can be in the form of an ice pick or a box scar or rolling scars, just to keep in mind. And also even acne can have hypertrophic or keloidal scars. Now, few special lesions such as comedones, like the one we see in acne. So the white closed heads that have keratin and sebum inside, and when they're open and oxidized or exposed to the oxygen and oxidized, then they become black, and we call them the open comedones, like we see here in the pictures, and we're all familiar with these. Burrow is another feature that is specific for scabies. So when we examine patients with scabies, we look very closely to those tiny tunnels under the skin where the mite is going and laying the eggs. A cyst is a special form of a sac forming, so it has a wall and different contents according to different types. An epidermoid cyst, as you can see here, with the content extracted. Now, this is the most important step, usually, the primary and the secondary lesions. So now we know what is it. Now we need to describe the other steps. So first, the color, as we saw. There are all kinds of color that we can see in dermatology. It can be the vascular red color or the characteristic salmon pink color of Pityriasis rubra pilaris. The lichen planus has this purplish characteristic color, or sometimes the brown pigment or color of melasma. Then we have the yellow fat color in xanthelasma under the skin, or the green characteristic color of Pseudomonas, or the pigment actually of that is produced by the Pseudomonas and gives this characteristic green color. Superficial onychomycosis of tinea, forming this white color, and the black color of necrosis. Blue nevus is not actually blue. It looks blue, but it's actually due to melanin deeper in the skin that gives this bluish hue. And finally, argyria, where you have this silvery gray color. Not only that, we're also in individual lesions, such as in melanoma or atypical melanocytic lesions, we always look for the different forms of color or different colors in the same lesion. So here, ranging from red to pink to orange to brown to black. So this is a suspicious lesion and need to be investigated and treated. So another important differentiation in color is in the skin of color, okay? And it's important to recognize in our region of the world, most of them are darker individuals with different, and the color of the lesions and is different from the description in books. Okay, so an example of this is lichen planus. Here on the left, we see the pink purplish color that is described in every textbook of lichen planus. However, in our part of the world, we see a lot of darker, dusky red to brown or even black papulousquamous disorders or lichen planus. So keep that in mind. Now, we described the lesion, we described the color, we move on to the shape. What do we mean by shape? It's either a dome shape, so forming a dome on top of the skin, or can have a central dent or indentation like a molluscum, for example, or we call this umbilicated, or verrucous, where have this velvety or filiform shape or verrucous, like a verruca, like a wart. Okay, so the warty appearance. And then the classic description of lichen planus also, that no matter how big is the plaque, they're usually flat-topped, so they don't grow vertically. And finally, the pedunculated lesions, where they have a body and a narrow stalk or neck underneath. Now, moving to the fourth step, how are they configured, how they arranged? So we have the discoid shape, okay, forming like a disc or a coin, like in annular eczema. They can be ring forming, like granuloma annulare or tinea corporis, or targetoid, like an erythema forme, where we have a target lesion where different circles, and grouped or clustered, which is characteristic of herpes or zoster. As you can see here, few lesions grouping together, and then a skip area, and then others. They can be arranged in a line, like lichen striatus, a straight line, or a zigzag line, like serpiginous, like Cutaneous larva migrans. Now, finally, the final step is distribution. How are they distributed? And there are different ways of describing this. Either they're involving mainly, so some diseases have predilection for the flexures, for example, such as in atopic dermatitis, where it involves the antecubital and popliteal fossa in front of the elbows, behind the knees. Or it has a predilection for the scalp and extensor surfaces, the presacral area, okay, such as in psoriasis or plaque-type psoriasis. Sebaceous distribution represents the distribution of sebaceous glands. So definitely acne will be distributed on the face, the neck, the central chest, and the upper back. Another type of distribution is the photodistribution in some sensitive disorders, like, for example, lupus, that can present with malar rash on the face and characteristically here, as we can see, in the V-neck. Another form of distribution is dermatomal, and this is characteristic of herpes zoster or varicella zoster. So zoster starts with a neuritis and then erupts in the skin that is supplied by this exact nerve. So it has a specific distribution that we call dermatomal. And finally, the Blaschkoid distribution or Blaschko lines, and those represent the lines of migration of cells in embryogenesis. So if you have a mutation after the formation of the embryo, or like mosaicism, basically you can have some skin lesions that appear in those lines of migration, like in lichen planus or lichen planus pigmentosus, and benign tumor called epidermal nevus. So what about this? Can you guess what is this? Let's say you know this is zoster, but what if you don't know? So let's apply the steps that we discussed, okay? So we're looking at the upper back. We have grouped vesicles of clear fluid on an erythematous base that is clustered or grouped together. And we have some secondary lesions of erosions and formation of yellow crusts. So this all tell me that those are vesicles. Some of them have ruptured, resulting in erosions. Some of them have dried fluid that left some yellowish crusts, and they are distributed in a specific dermatome. So this is the classic description for a zoster. Now, what about this? Those are, let's say, round papulosquamous lesions. They're scaly, red, in a distribution on the arms. I don't see anything on the body. I don't see anything on the lower limbs or lower body. This has a wide differential. This could be psoriasis. This could be, some of them are maybe annular, that can look like a tinea corporis. And maybe it's a discoid eczema or nammular eczema, that form of well-demarcated eczema. Is it itchy? Is it not? So sometimes we're puzzled, and the clinical, it's not following, it's not on the elbows, it's not on the knees, it's not in the flexural surfaces, it's not on the trunk. So it's not following any of the patterns that we classically know to diagnose clinically. So sometimes we don't know if this is a zebra or a donkey, okay? And in this case, it's actually a zonkey. So we need the biopsy to help us reach our diagnosis. So the whole idea of morphology is to how to describe lesions and how to narrow down the differential diagnosis. And if we can diagnose clinically, fine. If not, then we have other investigations to utilize to reach our diagnosis and take it from there. Thank you very much for listening, and welcome to any questions.
Thank you so much, Dr. Badr. That was an excellent start to the event. I have to say that in terms of the presentation, the slides, that's not only very helpful to the other specialties, but I think this will be very helpful for junior dermatology residents as well. And I think this talk should be given to them as well.
Thank you very
I think
much.
we have time for a few questions. Okay, so we have a few here.
Sure.
Let's start with the first question. So, can you tell the difference between a nodule and a cyst from a picture or photo?
That's a good question. So it's really difficult to tell many lesions actually by pictures, because as I said, the morphology depends on inspection and actually palpation. So palpating the lesion to tell if it's a solid or if it's fluctuant, like an abscess, for example, or if or if you can move it, and also close inspection to look for the punctum. The punctum is another characteristic of a cyst, like epidermoid cyst, or commonly known as sebaceous cyst, has a central punctum. So some people can actually, I mean, if you take a very close picture, close up, and we can appreciate the punctum, then I can tell that this is more likely to be a cyst rather than just a nodule. But sometimes it's hard to appreciate or see the punctum, and it's hard to tell. And some nodules can be tricky to see in pictures. So not all of them are elevated on top of the skin. Like we know, for example, in erythema nodosum, sometimes you see, like in the picture, you see redness, but you have to really palpate the lesion to see the nodularity in the skin and appreciate the tenderness and to be able to diagnose erythema nodosum.
All right, thank you so much. We'll take maybe one or two more questions. So let's see, what are the different types of scales and how are they relevant to differentiate between disease groups or different diseases?
Okay, this is an excellent question, actually. So different scales, I mean, scaly disorders, we generally like classify them into either papulosquamous or eczematous, and sometimes as secondary changes in vesiculobullous disorders. But we classically depend on the scales in papulosquamous disorders, and we look very closely to differentiate between the different types. For example, in psoriasis, have this thick, white, silvery, or micaceous scales that are very adherent to the top of the lesion. And actually, we have the Osbit sign that if you try to remove some of those scales, you will have pinpoint bleeding. Another different type of scales is the, for example, in Psoriasis rosea, or Nakhal al-Wardiyya. We have those marginal scale that are trailing toward the inside at the periphery of the lesion. And this is another clue that this is lesions of Psoriasis rosea. Sometimes in Psoriasis versicolor, we have this fine powdery scales, and sometimes you don't see it clinically and you need to rub or scratch the surface of the lesion to appreciate those powdery fine scales. So for example, Tinea corporis have annular or marginal scales at the periphery.
Okay, so let's take a couple of quick ones. So what are the red flags in morphology that prompt urgent care?
Wow, okay, that's an excellent question. So let's say first come to mind is actually blisters. Blisters can be, in many times, a dangerous sign, but not always. So especially if we're suspecting a drug reaction in the form of Stevens-Johnson syndrome, or TEN, or fixed drug eruptions, or other forms of adverse drug reactions. Or a flare of bullous pemphigoid that is severe, or pemphigus that is progressive and sometimes may require admission and prompt treatment. Targetoid lesions or target lesions is another lesion that's seen in severe cases or dangerous cases, such as in erythema multiforme or Stevens-Johnson's or TEN as well, that can be targetoid in morphology. Vasculitis, so I did not maybe mention that in the primary lesions, but vasculitic lesions or purpura, that of course we have different descriptions from petechiae to larger purpura that is palpable or non-palpable, and then we have ecchymosis with our larger hemorrhagic lesions. Now, if we see any of those, or and particularly palpable purpura can represent vasculitis, and vasculitis is a broad topic that some of them are really dangerous and require immediate attention.
Excellent. Maybe time for, let's say, maybe one more.
All right.
For primary versus secondary lesions, do you mean the secondary is developed from the primary lesion, or it can be secondary from the start?
Most of the time, it's starting from primary lesions, either noticed or unnoticed by the patient, or like those are the first early stages of the disease that quickly transform from primary to secondary. Usually secondary are modified primary lesions, so changed over time, like a blister that ruptured and resulted in an erosion or a crust, or due to exogenous, like for example, scaly papule or plaque of eczema that was scratched or rubbed and resulting in formation of excoriations or lichenification. I can't think honestly of a secondary lesion that starts right away. Maybe an atrophy is considered, atrophy of the skin maybe is considered a secondary lesion, but not necessarily there is a primary lesion unless, I mean, sometimes there is subtle inflammation that started in the skin, maybe not noticed, and then resulted in secondary atrophy. Maybe you would have other examples to add?
I mean, I think that's very informative. I think you
Thank you.
got the question there. So can cysts have more than one punctum?
Can cysts have more than one punctum? Oh, I think yes. I mean, what I can think of is hidradenitis suppurativa, where we have some cysts or abscesses, and they can have a double. I mean, we can consider it a cyst and can have a double comedo or double punctum, double blackhead. But I've never seen, honestly, a cyst with more than one punctum. Yeah.
So we got you with a lot of questions. That's because we had some extra time, but these are very good questions. I see a lot of other questions. There are a lot of questions that are unrelated to this lecture per se, but definitely related to some of the other lectures that we'll be having later on today and tomorrow. So please ask your questions again during those lectures, and hopefully we'll get a chance to answer them at that time. Again, thank you so much, Dr. Badr, and I think we'll see you shortly, maybe about half an hour or so, with another hopefully very good talk. So thank you again.
Thank you very much. My pleasure.
Okay, all right, so let's move on to our second talk, and it gives me pleasure to introduce Dr. Sahal Samarqandi, consultant and assistant professor, King Abdulaziz Medical City and College of Medicine at King Saud bin Abdulaziz University for Health Sciences in Jeddah, Saudi Arabia. And Dr. Sahal will be talking to us about red faces. So Dr. Sahal, the mic is yours.
طيب, can you hear me? Can you see me now?
We can see you, Dr. Sahel. We can hear you and see you.
Okay, what about the slides? Is it visible to you?
We can see the slides very clearly.
Okay, that's good. طيب, بسم الله الرحمن الرحيم. First of all, I would like to thank Saudi Society of Dermatology and Dermatologic Surgery and the organizing committee for organizing such a great and beneficial webinar. And thank you for giving me this chance to present this important topic, which is red face. So let's start. Bismillah ar-Rahman ar-Rahim. Facial skin changes are important as they are embarrassing and can lead to loss of self-esteem and impair quality of life. There are many causes of red face. These ranges from inflammatory skin disease, infections, allergies, photo damage, or cutaneous manifestation of multisystem disease. Of course, face cannot be separated from other areas. So complete skin examination is very important to reach your final diagnosis. We will go a little bit in detail about the common causes of red face, and then we will go quickly over the less common and the rare causes of red faces. Okay, let's start with the most common skin disorder in dermatology. This patient has multiple erythematous papule and pustule. I'm sure that all of you know what is this. This is acne vulgaris. If we can say this is a moderate type of acne vulgaris, which is the papulopustular type. And this is another example of acne patient who has multiple erythematous papule and pustules. So again, this is a moderate type or the papulopustular type of acne. This is the comedonal type of acne. We are seeing here multiple blackhead or open comedones, as well as closed and or white head comedones. So this is the mild type of acne. So what is acne vulgaris? It is a common disorder. Actually, it is the most common skin disorders. It involves the pilosebaceous unit of the skin, and it affects about 85% of people during their lifetimes. Of course, it usually started most commonly after puberty. So this is in brief about the pathogenesis of acne. After puberty, we have, of course, increase in the androgen level, which lead to increase in the sebum production from the sebaceous gland, and we also have sebaceous hyperplasia. And in addition, we have hyperkeratosis and the retention of keratinous material in the follicular epithelium or the follicular opening. This will lead to the formation of what we call comedones, either closed or open comedones or the blackheads. Of course, the color is due to the oxidization. If this comedones become continuous, we will have later on we have an inflammation. Then we call it clinically inflammatory papule and pustules. And in addition, we have the formation or the growth of P. acne, Propionibacterium acne, currently called Cutibacterium acne. If this inflammation is not treated, we might have further nodules and cysts with intense inflammation. So we have here inflammatory acne, and here we have non-inflammatory acne. Again, another way to classify or to stage acne, either mild, moderate, and severe form of acne. So this is the different type of acne. Again, let's go quickly. This is mainly comedonal acne. This is mainly papulopustular acne with of course, some comedones as well as acne scars. We are seeing here rolling scar as well as ice-pick scars. This is the severe form of acne, where we see here multiple nodules and cysts. So again, the classification of acne based either into the severity or the inflammatory or non-inflammatory. These are some examples of acne variants, which include acne conglobata, the severe form of acne, where we have multiple nodules and cysts in the truncal area, in addition to the association with the other follicular occlusion triad, including hidradenitis suppurativa and the dissecting cellulitis of the scalp. Acne fulminans is the severe, again, a severe and rare form of acne, usually triggered by the use of isotretinoin and sometimes spontaneously, and it is usually associated with systemic manifestation, and in addition to some lytic bone changes. We have other, of course, the other rare variant of acne, which include infantile, neonatal, color acne, occupational acne. The list is very long. Okay, let's go to the treatment option of acne. We usually start with the topical retinoids. The most commonly used is tretinoin and adapalene. I usually advise the patient to use it like twice weekly or every other night, with very, very minimal amount to limit the irritation that is caused by topical retinoids, because it is comedolytic and it's a peeling, superficial peeling agent. In addition to topical retinoids, we can advise the patient to use antibiotics, especially for inflammatory type of acne, such as erythromycin, clindamycin. But the problem with these topical antibiotic is the resistant. Patient can have resistant from these topical treatment. So that's why we use benzoyl peroxide to minimize the resistant. Benzoyl peroxide is good, can have an effect within 2 to 4 weeks. But the problem with the benzoyl peroxide is the irritation. That's why patients they don't like benzoyl peroxide. Topical dapsone is new and it's not routinely used. Azelaic acid is another treatment and good option, especially for patient who has acne, as well as post-inflammatory hyperpigmentation. If the patient is not happy with the topical treatment, we can jump and use systemic antibiotics such as tetracycline. The most common one is the doxycycline. I usually give it in 100 milligram PO daily for 6 to 8 weeks. It will give a good result, but the problem, it can recur. There is another also example of oral antibiotic, including macrolides and Bactrim. Of course, systemic retinoids, the most commonly used is isotretinoin. This is the gold standard. Actually, it is considered one of the best treatment option in acne. It's very effective. However, there are so many side effects, including dryness of the skin, dryness of the mucosa. It is teratogenic, so it's category X in pregnancy. And of course, you need to do lab before and after, just to avoid the liver increase in liver enzyme or increase in triglyceride or cholesterol. Okay, we are done from acne. Let's go to another topic. This is a very common disease. This patient, male patient, I can say in his 30s or 40s, he has erythematous patch centered around the nose as well as the cheeks. So this is, of course, rosacea. This is the stage 1 rosacea, where we call it erythematous rosacea or erythematotelangiectatic type of rosacea. So rosacea is a common chronic inflammatory acneiform disorder of the pilosebaceous unit, affect 10% of fair-skinned people. However, we can see it also in our population, but the problem with our population, the dark skin, usually we cannot appreciate very much the erythema. But sometimes you can diagnose the patient based on history. The patient might complain of burning or flushing and blushing from time to time, especially with upon exposure to sun. The peak incidence between age 40 and 50. Female are morely affected than male. However, male are usually complain more of rhinophyma, and I will show you a picture of rhinophyma. So rosacea, usually a patient with rosacea present with papule, pustules, erythema, as we mentioned, in the face, in the sun-exposed area mainly. In addition to history of flushing, that is usually triggered by sun, by heat, spicy food, emotional stress, and so many other triggers. So staging, let's go with the staging of rosacea. So as we mentioned, this is an erythematotelangiectatic type of rosacea where we are seeing erythema mainly in the central face, and the patient usually complain of burning and stinging sensation. This is stage type of rosacea, which is the papulopustular type, in addition to erythema and telangiectasia that we are seeing here on this lady. One of the characteristic point to differentiate rosacea from acne is that rosacea has no comedones, while acne we see comedones. So this is a papulopustular type of rosacea. This is stage 3, where we usually see more pronounced papulopustular lesion and erythema, in addition to the swelling and edema. We call it solid edema of the face in this patient. So this is stage 3 rosacea. We have phimosis rosacea, which is the hypertrophy and the appearance of or the prominent follicular opening, especially on the nose. So this is, we call it rhinophyma. Usually we see it more commonly on male patient. We have, of course, other type of phimosis rosacea based on the location. Of course, treatment here is debulking, surgical excision either by scalpel or electrocautery or laser. There are other variant of rosacea, which include granulomatous, steroid, ophthalmic rosacea, and a severe form of rosacea, which is rosacea fulminans. And there is another rare form, which we call it Morbihan disease. Treatment option, of course, it is very important that you educate the patient to avoid sun and avoid other triggers that we mentioned early. Advise also the patient to apply sunscreen, especially that the one that has protection against UVA and UVB with the SPF 30 and above. We can also give topical clindamycin, topical erythromycin. We can also give topical metronidazole. However, metronidazole is not effective in erythematous rosacea, but maybe it is helpful in papulopustular type of rosacea. Topical ivermectin or Solantra. This is a new and effective treatment. Actually, it is more effective than metronidazole. And can be used together, ivermectin and metronidazole. Topical alpha agonists such as brimonidine tartrate or oxymetazoline also can be used, especially for erythematous type of rosacea, because it acts as a vasoconstrictives. If the patient is not happy with the topical treatment, we can go with the systemic treatment. We can give antibiotics such as doxycycline. Doxycycline is advised to be given in a low dose, such as 40 milligram, because it shows that 140 milligram is equally effective. However, the 40 milligram has lower side effects. So usually we give 40 milligram daily for, let's say, 1 or 2 months. Isotretinoin is also effective in rosacea, but the problem, it can recur again after discontinuation of isotretinoin. For the severe form of rosacea, we can give, in addition to isotretinoin, we can give brief course of oral steroid. For phimosis rosacea, we can go, as we mentioned early, with the debulking surgery, and also we can use fractional laser, such as fractional CO2 laser. Okay. Let's move to the next topic. This is a female patient who has multiple erythematous papule and pustules around the mouth, as well as around the nose and the nasolabial fold. So this is, we call it perioral or periorificial dermatitis. So what is periorificial dermatitis? It is an inflammatory condition of unknown cause. Some authors related this disease to rosacea, while others consider it as a separate disease. It is well known that this disease is triggered mainly by topical corticosteroid and sometimes by the use of facial cosmetics. It is most commonly seen in young women in their 20s or 30s. Children also can be affected. So as we mentioned, these are the clinical feature of periorificial dermatitis. We can see it also around the periorbital area. And the patient usually complain of burning sensation rather than itch. So treatment option, actually, it is a self-limited disease that can resolve with time. The most important aspect here is to avoid the triggers. We're talking here about mainly topical steroid. Sometimes we can give oral antibiotic, doxycycline, for let's say 8 weeks. But it is very important that we gradually taper the oral antibiotic in order not to have a rebound. Pimecrolimus and tacrolimus can be used. Clindamycin topical in a topical preparation, as well as metronidazole can be used as a topical treatment. Okay, let's move to next topic. This is a patient who present also with the red face. So we are seeing here scaly erythematous patch, and the scales is ranging from white to yellow to orange, mainly in the nasolabial fold, cheeks, foreheads, eyebrows, and in the preauricular area. If we ask the patient, do you have scalp involvement? I'm sure the patient will answer, yes, I have dandruff. So this is seborrheic dermatitis. So what is seborrheic dermatitis? It is a common chronic skin condition characterized by redness and scales in area rich with sebaceous glands such as the face, scalp, chest, and body folds. The mild form of seborrheic dermatitis called dandruff, which is, I'm sure most of you have this problem. We can categorize seborrheic dermatitis into two different types, the infantile and the adult type. Usually infantile started within the first month, and the adult type can start anytime after puberty, but the peak incidence between 20 and 50 years of age. There are many predisposing factors that lead to seborrheic dermatitis, which include the, of course, genetic causes, as well as the presence of Malassezia furfur. Sometimes we see seborrheic dermatitis in patient who has some neurological problems such as Parkinson's disease, as well as patients who are immunosuppressed. So these are some pictures of seborrheic dermatitis. We are seeing here scaly to actually white to yellow scales and dandruff. And also sometimes in severe form, we are seeing the yellow greasy looking scales in the nasolabial fold, as well as the eyebrows and the eyelids. This is the infantile form. Usually the baby present with this thick scales on the scalp. We call it cradle cap. So treatment option based according to the age. So in infantile type, it is self-limited. Usually within a few months it will resolve. We can advise the family to apply emollient. We usually recommend olive oil preparation that can be used during showering. We can add it with the baby shampoo and with the gentle rubbing, only gentle rubbing, not mechanical removal. It's very important that advise the family avoid mechanical removal of a scale. Only gentle rubbing of the scales can lead to its removal and gradually, as we mentioned. We can add topical ketoconazole cream or low potent topical steroid or pimecrolimus. In adult type, we can give ketoconazole cream or shampoo, topical corticosteroid, whether as a cream or shampoo. Selenium sulfide also is effective as shampoo. Sometimes we can use pimecrolimus or tacrolimus for facial involvement. In severe form of seborrheic dermatitis, we can give oral itraconazole for 2 weeks. Sorry. Okay, let's move to another topic. This is a female patient who has this erythematous scaly vesicles and papule on the lips and around the lips after she applied certain type of lipsticks. So I am sure from the history you can tell that this is contact dermatitis. This is a male patient who presented with this very itchy, scaly, erythematous patch on the face after exposure to poison ivy. So again, contact dermatitis can manifest sometime as a red face. So contact dermatitis can be categorized into acute or chronic, and also it can be categorized either into irritant or allergic contact dermatitis. So this table summarizes the difference between irritant and allergic المعذرة في interruption. طيب, there are two type of, as we mentioned, contact dermatitis, the irritant and the allergic type of contact dermatitis. The irritant type is caused by the some irritant materials such as certain acids and alkalines, which can cause erosion and abrasion in the skin, and it can happen to everyone. While allergic contact dermatitis usually caused by certain topical preparation or certain substances or materials, and the patient later developed sensitization and the appearance of rash after contact with this allergen. And there are also other ways to differentiate. Usually irritant, the patient complain of more pain and stinging rather than itch, which is usually seen in allergic contact dermatitis. Irritant usually confined to the area which is exposed to the irritant material, while allergic contact dermatitis might spread beyond. Of course, irritant caused by irritant substances, while allergic is caused by type 4 hypersensitivity reaction. Okay, let's go to another topic. So now we will move quickly because this topic will be covered inshallah later. So this is a child who has a scaly erythematous patch on the face. I'm sure that all of you know this is atopic dermatitis. Can also present as a red face. This is a different patient who has the same problem. If you can notice, we are seeing here well-defined scaly erythematous patch that spare the nasolabial fold, and it is mainly located on the cheeks and also the nose. So this is, we call it malar rash, and malar rash is considered one of the characteristic signs in systemic lupus erythematosus. So this is acute form of cutaneous lupus erythematosus. This is again lupus erythematosus, but the chronic form of lupus erythematosus. This is different patient who has the same problem. We call it discoid lupus erythematosus. So usually discoid lupus erythematosus patient present with these erythematous, scaly, atrophic, and dyspigmented plaque located on the face, sometimes on the ear with the follicular prominence, as you can see here, and the scalp involvement with the cicatricial alopecia. So this is a chronic type of lupus erythematosus. We call it discoid lupus erythematosus. So lupus erythematosus can be categorized into specific cutaneous lesion and non-specific cutaneous lesion. The specific one subcategorized into acute, subacute, and chronic. The most common example of acute is the malar rash and the photosensitivity. And this is, of course, has high risk or correlated more with the systemic disease, while the discoid type has very, very low risk of having systemic involvement, while the subacute is in between. And also we have the non-specific cutaneous rashes that is characteristic for lupus, but it is, of course, non-specific for lupus erythematosus. This is another connective tissue disease. We are seeing here on the upper eyelids a heliotrope rash, which is violaceous rash, and lower eyelid edema. Of course, this is another example of heliotrope signs and the appearance of what we call it Guttrum papules and the nail fold changes, including nail fold telangiectasia. So this is, of course, are characteristic signs of dermatomyositis. So we can classify dermatomyositis into different types. We have adult and we have juvenile type. The adult and juvenile both can have classic type. The adult usually have characterized also. There is another type, we call it classic dermatomyositis with malignancy. And also we have clinically amyopathic dermatomyositis and an overlap also with other connective tissue disease. Of course, as all of you know, that dermatomyositis is not only a skin condition, but it can also have systemic involvement, mainly muscle and lung, among other organs. And these are some characteristic rashes that we usually see in patient who has dermatomyositis. Let's move to another type of red phase. These are some erythematous to violaceous papule and plaque that is mainly present in the nose as well as the cheeks, and sometimes have an ulceration. And the characteristic signs of this disease is what we call it dioscopy sign, where we can see here apple jelly appearance. So this is cutaneous sarcoidosis or lupus pernio. Lupus pernio is like this, the facial involvement or the nose involvement. So sarcoidosis, as you know, it's a multi-system disease. Can involve the skin, lungs, and other organs. And the most common cutaneous manifestation is the papule and the plaque that is usually most commonly seen in the face and nose. And also one of the non-specific but usually associated with sarcoidosis is the presence of erythema nodosum. Of course, sarcoidosis is considered as granulomatous disease. We are seeing in the histopathology non-caseating epithelioid granuloma or naked granuloma. Okay, so we are done from sarcoidosis. This is another disease that presents with red face. We are seeing here red swollen face in this lady. So I'm sure that all of you know that this is angioedema. So angioedema either can be alone or can be associated with urticaria. And of course, urticaria can be categorized into acute and chronic. Angioedema can be categorized into hereditary, acquired type. So I will not go in the details of angioedema. But as I told you, angioedema can manifest also with the red face, with swelling of the eyelids, mouth, nose, and cheeks. Okay, this is another example of patient who present with red face. This is a young boy who presented with this exanthematous eruption and facial edema after starting anti-epileptic drugs. And of course, one cause is the presence of erythema, not only on the face, but also exanthematous eruption on the trunk. So this is, we call it DRESS syndrome, or drug reaction with eosinophilia and systemic symptoms. It will be, inshallah, discussed later during lecture drug eruption. Let's go quickly to some other causes of red face. This is this is patient with the painful swelling, painful erythema on the face. We call it erysipelas. This is multiple annular scaly erythematous patch. This is tinea fasciae, which is dermatophyte superficial fungal infection. This is unilateral dermatomal involvement with red face, as well as crust erosion. And this is, of course, all of you know, this is ophthalmic zoster. This is a viral exanthem. Patient present with the red face. We call it fifth disease or slab cheek appearance. This is caused by parvovirus B19 infection. This is a sun-exposed area. Patient with the polymorphous light eruption can also present with red face, as well as papule and plaque and patches in sun-exposed area. So we are done from my lecture. This is the last slide, take-home message. Red rash on the face can include uncountable number of conditions. It can be isolated sign, or it can be part of other skin lesion. Examination of other areas, taking detailed history, and using available bedside and diagnostic tools will help you in diagnosis. Always pay attention to primary and secondary lesion. And one way to help you reach your diagnosis is to categorize these diseases into categories such as eczematous, follicular, connective tissue, or, for example, granulomatous disease. Thank you very much. I hope that you enjoy my lecture. And now it's the time to take question. And if you have any further queries, you can contact me through email or through social media link.
Thank you so much, Dr. Sahal. That was very, very informative. And I think it has one of the most important maybe diseases that maybe family care physicians face on a daily basis. I think we got a lot of questions from different doctors. Due to the time, we'll just try to maybe answer a few questions very quickly. So we had a question about, is topical retinoids contraindicated in pregnancy?
It is considered category C. However, because of the isotretinoin, which is from the same family of drug, which is considered category X, that's why usually we advise not to use topical retinoid during pregnancy. But anyhow, there is no evidence support any harm from using topical retinoid.
Excellent. There were actually multiple questions about differentiating between rosacea and malar rash. And I know you touched upon this, but do you mind just maybe repeating this quickly?
Yes. Okay. So rosacea and acne, maybe the question is about rosacea and acne. Acne are usually more common in after puberty, while rosacea...
Sorry, Dr. Sahal, rosacea and malar rash.
Sorry. Rosacea and malar rash of lupus. Of course, lupus, you can have other systemic involvement. Of course, rosacea, you might have telangiectasia, you might have papule, pustule. The patient usually will complain of stinging, flushing, while in malar rash, usually it is asymptomatic. The patient will come to you with only asymptomatic malar rash, in addition to other signs of lupus.
Okay, perfect. So we'll take maybe one or two quick ones. When do you recommend isotretinoin or roaccutane for acne vulgaris, and for how long?
Of course, in moderate and severe type of acne, I usually start isotretinoin. And if the patient, even if he has mild acne, if maybe he had before coming to my clinic, maybe he had moderate to severe. But if I see scar, acne scar such as ice pick or rolling scar, I usually start isotretinoin. And for how long? Usually based on cumulative dose, around 120, sometimes to 200 milligram per per kilogram, usually from 6 to maybe 10 months. Of course, depending on the dose and the weight of the patient.
Okay, so one more question. It was written in Arabic. It's asking about benzoyl peroxide. كيف نشرح للمرضى استخدام هذا الدواء صباح مساء؟ هل يحتاج واقي شمس وكم مدة الاستخدام? So basically, benzoyl peroxide, how long do we use it in the morning or at night? Do we need sun protection? And how do we explain using it to the patients?
Sun protection, if you notice that your acne is triggered by sun, yes. But if you are using tretinoin at night time, you can use sun protection at daytime. But benzoyl peroxide, if you use it alone, you don't need to use sun protection. But the problem with benzoyl peroxide, as I said, it can cause severe irritation. But within 2 to 4 weeks, usually it has we can see a result. Sometimes if the patient cannot tolerate benzoyl peroxide to be applied all over the face, we ask them only to apply it only on the inflamed lesion, like papules or pustules.
All right. Thank you so much, Dr. Sahal, for your time and a very good talk. Okay, so we're actually going to head back to Dr. Badr Zimmo. Just in case people who weren't with us earlier, just a quick introduction again. Dr. Badr Zimmo is a consultant and assistant professor of dermatology at King Abdulaziz University in Jeddah. And this time he'll be talking to us a little bit about psoriasis, basic information, and maybe touch upon some of the treatment options for psoriasis. Dr. Badr, please.
Sure. Let me just put my slides. Assalamu alaikum wa rahmatullah marra thaniya. Welcome back. It's a pleasure for me to be with you twice today. Now we're going to talk about a very important and common topic, so psoriasis. Okay, al-sadafiyya. So what are we going to talk about? First of all, what is psoriasis? What is the underlying pathophysiology? And what are the different clinical presentations and variants of psoriasis? With focus on the triggers, modifiable risk factors, and other comorbidities other than the skin that are associated with psoriasis. And then a brief introduction into therapeutics with a focus on topical treatments that are used for mild to moderate disease. And how we can work together hand in hand as a multidisciplinary team to optimize management and counseling of our psoriatic patients. So what is psoriasis? We used to think it's a skin disease or only a skin and joint disease, but no, actually it is a multi-system disease with predominant skin and joint manifestations. But there are other comorbidities, including coronary artery disease, metabolic syndrome, including diabetes, hypertension, increased weight or obesity, and depression and other psychiatric issues, among others. So we need to understand that the nature of this disorder, that it's a chronic disease that waxes and wanes throughout the lifetime of the patient. Unfortunately, there is no complete cure, but excellent control and reduction of comorbidities is achievable and now more than ever because of the newer biologics and newer treatments that are available for us now. So it affects about 2 to 3% of the world population. There is a racial and geographic difference, so it's higher in Caucasian and lower in Africans and Asians. Both sexes are affected equally and can occur at any age, but it has a characteristic bimodal age distribution. Now, it's a T-cell-driven immune dysregulation. So that's the main pathogenic statement, let's say. The T-cell-driven immune dysregulation. So it's a how does this happen? It's a multifactorial disease. There is a genetic predisposition and there are environmental triggers. In terms of genetic predisposition, HLA, or human leukocyte antigen, CW6 allele, has the strongest association among other identified locations on chromosome. At least 8 have been identified till now. What about environmental triggers? There are 2 main ones, the infections, especially group A beta hemolytic strep, and some medications. And other exacerbating factors behavioral, such as smoking, alcohol, obesity, and stress. Now, in terms of the molecular pathogenesis, we used to think historically that psoriasis is just a hyperproliferation of the skin and that's it. But now with the advancement of the research, we were able to pinpoint more the culprits of the disease. So we know that it's a complex immune-mediated disease in which T lymphocytes, dendritic cells, and keratinocytes play together a central role and communicate with each other to propagate the inflammation. And the main players or the main messengers in between them in terms of cytokines are interleukin-23, interleukin-17, and TNF-alpha. Maybe this is to dwell more, it's beyond this lecture, but we need to know that those are the targets of the newer biologics that have advanced our treatment of psoriasis. So the end result of the inflammation on the skin is that there is hyperproliferation of the keratinocytes. There is abnormal differentiation. So this will result in thickening of the skin and accumulation of scales on top, give us the characteristic lesions of psoriasis or plaque type psoriasis. And there's also inflammatory cell infiltrate and vascular dilatation. Now, similar inflammation happens in the joints. And it's important to note that there is osteoclast activation and there is erosion and destruction. So it's an erosive form of arthritis that happens in the joint and can result in permanent disability. So what about the clinical features? So let's take a look at the different types and different pictures. So we classify psoriasis into different types. Each of these types have their own phenotypic appearance and have their own sort of natural history and even their own differential diagnosis. The most common being the chronic plaque type psoriasis. So let's take a look at that. Now, it's 80 to 90% of patients with psoriasis have the chronic plaque type. Typically, the lesion, if we look at the individual lesion of psoriasis, as we can see, it's a very well-defined, sharply demarcated erythematous plaque, and it's covered with silvery white or sometimes thicker micaceous scales. And it can be irregular, round to oval, and it can range in size from 1 to several centimeters and may coalesce together into larger plaques and even be widespread, covering large areas of the body. Some of these lesions would develop painful fissures and cracks in the lesion, and especially in lesions over joints or in the palms and soles. Now, this is in terms of the individual lesion. Now, how are they distributed? They have a characteristic distribution. So basically, they're symmetrically distributed in the body and have certain predilection sites, mainly the scalp, the extensor surfaces, such as the elbows and knees, and also the presacral and intergluteal areas. So this is the classic description and the classic distribution. Now, in terms of severity, most patients have mild to moderate disease, whereas more than or less than 20% have more moderate to severe. Some would define this as more than 5 or more than 10% body surface area, or sometimes it's not necessarily widely distributed, but involving crucial areas such as the hand, the feet, face, and genitals. So let's take a look at some pictures here. And so psoriatic plaque involving the scalp, it can be 1 to several isolated plaques, or can involve the entire scalp and classically have this margin at the hairline. Another area of predilection is the extensors. So we can see it here, sharply defined, scaly on the elbows, as well as on the knees, presacral area, and widely distributed, involving the extensors, presacral area, and classic areas, and also on the trunk and extremities. Okay, so more widespread disease. Now, the textbook color description is erythematous, salmon pink color, but remember also in our area or in darker skin, or it can have a different morphology and different colors. So here we can see it's paler pink to hypopigmented with hyperpigmented peripheries. So keep that in mind as well. Sometimes you can see them red with very minimal scales, sometimes have those classic textbook silvery white scales. and it can involve other areas in a localized form. So the palms and the soles can be isolated alone in a form called hyperkeratotic palmoplantar psoriasis, and sometimes can be part of the generalized psoriasis. Rarely, it can affect the face, and rarely can present in pediatrics or in children. Another characteristic sign is Koebner phenomenon or Koebner sign, which is an isomorphic response in where any injury to the skin will elicit the development of psoriatic lesions at the site of injury, as we can see here at the site of surgical scar and sutures, or the train track appearance. Now, this is the most common type in 80 to 90% and has its own differential. Now, what about inverse psoriasis? What does inverse mean? Basically, involvement of the intertriginous areas, meaning skin folds. So any area that is folded by the skin. Okay, so typically those lesions, because of the nature and the location of those lesions in the folds, they're bright red with minimal scales because those areas are moist due to sweating and due to occlusion and under mechanical friction and pressure, so many of the scales are removed. So they're bright red with minimal to no scales. What are these areas of involvement? What are the skin folds? There are axillary as in this picture, and here under the breast, as we can see, also still has a sharp demarcation. Of course, here it has a lot of other differential, including other inflammatory disorders, infectious, like tinea or candida, and the sharp demarcation, absence of satellite lesions, and of course, we look at others. And whenever you're in doubt, you need to consider your differential diagnosis and take maybe a scale send it for culture. So keep that in mind. And the umbilical region is another area that's involved in inverse psoriasis. The intergluteal, the inguinal, and the genital area. Again, well demarcated, bright red, minimal scales. More severe variant is the erythrodermic psoriasis. So what does erythroderma mean? Erythroderma means generalized redness and scales, or erythema and scales, covering more than 90% of the body surface area. And it's not peculiar to psoriasis only, but it has its own differential, but psoriasis is one of the commonest causes, or the top 4 or 5 causes of erythroderma. So when it's caused by psoriasis, we call it erythrodermic psoriasis. And this can start de novo, or the first time present with erythroderma, or maybe a patient who had plaque psoriasis for a long time, and then all of a sudden, due to an environmental trigger, let's say, or medication or something that flared up into erythroderma. This type is severe. It's associated commonly with fever, chills, malaise, the patient is sick, and lymphadenopathy is also common. Those patients are at risk because of the blood perfusion, the increased blood perfusion of the skin all over the body or all over the skin, and because of the increased cardiac output to the skin and increased water evaporation through the skin, they are at risk of fluid and electrolytes imbalance, as well as hypothermia, hyperthermia, and even if they have pre-existing weakness in their heart, it can push them into high cardiac output failure. This is an example of erythrodermic psoriasis with minimal scales, more moderate scales, and extensive scales. So these are all erythrodermic patients, and we're going to talk briefly about the management of those patients. Now, another variant is pustular psoriasis. If we look at histology, any lesion of psoriasis will have some neutrophils, but when those are evident clinically, then we call it pustular psoriasis. And there are many different types, can be localized or generalized. Those are not that common, but just to keep them in mind. Now, there is a localized form that's called palmoplantar pustular psoriasis, only limited to the palms and soles, or it can be widespread in pre-existing plaques, either in an annular distribution or just diffuse distribution, or there is a rare severe variant called von Zumbusch, or acute generalized pustular psoriasis, in where there is a whole like a background of erythema with pustules all over, and the patient is really toxic and sick with fever and chills. Now, this is a form of localized palmoplantar pustular psoriasis. As you can see here, the characteristic yellow pustules and brown macules. here involving the palms, and here in the inner step of the sole. And you can see a well-demarcated plaque, erythematous scaly plaque in the background, and then pustular eruption at the peripheries and in the middle as well. And this is the form of generalized pustular psoriasis, or von Zumbusch. Okay. Now, finally, the last form, it's a sort of acute form, the guttate psoriasis. It's an acute eruption usually. It starts suddenly, either with pre-existing or without any existing psoriasis, and usually affects the children or young adults. It's described as guttate, meaning dewdrops-like or dewdrop-like. They range in size from 1 to 10 millimeters, so generally less than a centimeter, salmon pink to erythematous, and they are usually distributed on the trunk and proximal extremities. So in contrast to the chronic plaque type, those are more acute. In contrast to the chronic plaque type, they're smaller and more numerous in number and mostly on the trunk and proximal extremities rather than the extensors, the scalp, and other areas. So as you can see, each type has its own phenotype, has its own chronological progression, and have their own triggers as well sometimes. So guttate psoriasis is classically preceded by an infection, in particular group A beta hemolytic streptococcal infection, anywhere in the body, but most commonly an upper respiratory tract infection. Okay. Now we see it, as we said, in children, as we can see here, multiple. The individual lesion is again a well-demarcated erythematous plaque covered with silvery adherent white scales, but the size is small and they're widely distributed and hundreds of them. At the abdomen, on the back, and also on the proximal extremities, and can be also on the distal extremities. Finally, a nail psoriasis. So nails are commonly involved in psoriasis, even in plaque type psoriasis, in any type of psoriasis, okay? And it sometimes, or many times actually, can be helpful in helpful as clues to the diagnosis. So it occurs in about involvement of the fingernails happens in about 50%, or so more than half of the patients, and toenails less frequent. There are 4 cardinal or characteristic signs, but they're not only specific to psoriasis, but they're commonly seen in psoriasis. And these are pitting, onycholysis, subungual hyperkeratosis, and the oil drop sign. I will show you some pictures. And just to mention that there's a strong correlation between psoriatic arthritis and nail disease. So this is pitting. This is the tiny depressions in the nail plate. Onycholysis basically means separation of the nail plate from the nail bed. So extension of the white edge of the nail plate. And then subungual hyperkeratosis, meaning scales forming underneath the plate, and the oil drop sign. Now, another sign is nail dystrophy in progressive cases or in advanced cases. And we can see here involvement of psoriasis in the distal digits. So nail signs can be subtle, like this petting and some degree of onycholysis, or very extensive and can cause major morbidity. And this alone can be an indication for systemic and aggressive treatment. And as we said, less frequently, toenails are affected. So as we saw, it's mostly a clinical diagnosis. We look at the specific features. If it has the characteristic presentation with the typical lesions and a typical distribution, and we're sure the diagnosis is a clinical one, whenever we're in doubt, or there's a wide differential diagnosis, or it has other non-specific or unusual presentations, then we need to do a biopsy that help us in the histopathology. Okay, so we have to assess the severity. We have many assessment tools in our hands. The most commonly used in clinical trials is the PASI score, but for simplicity, we commonly use the percentage of the body surface area involved, and this something that you can use as well, where we define less than 5 to 10% as mild, and more than that is moderate to severe. Another score to assess not the cutaneous lesions, but the quality of life impacted by the psoriasis is the general dermatology life quality index, or more specific psoriasis quality of life 12 item instrument. Okay, So other than the skin, what are the other comorbidities associated? And here we work together. So important for all of us, all specialties, to be aware of the different manifestations of psoriasis. As we said, it's a multi-system disease. And one of the commonest affected are joints. So psoriatic arthritis happens in about 30% of patients. It's a form of seronegative spondyloarthropathies. So commonly associated with enthesitis, dactylitis in young adults. And there are 5 subtypes of joint manifestations that are described for psoriasis. But the most common being the asymmetric oligoarthritis. So basically involve the interphalangeal joints of the hands and the feet. Other joints such as the wrist, the ankle, the elbow, the spine, and even the sacroiliac joint in a form like ankylosing spondylitis can also be involved. And what's important to know is that skin precedes the arthritis in about, or in the majority of patients, often by years. So here comes our role, all specialties, to screen patients. Whenever we see a patient with psoriasis, we always must be proactive and ask about symptoms and look for signs of arthritis. Because remember, it's an erosive, destructive type of arthritis that can result in a permanent destruction or permanent disability and major morbidity. Another important comorbidity is the effect on the heart. So not only this, patients tend to be, patients with psoriasis tend to be overweight and with an increased incidence of diabetes, hypertension, dyslipidemias, and they generally have a higher incidence of myocardial infarction, especially in severe cases. And also a recent meta-analysis has showed that increased mortality risk from all causes, or there is an increased mortality risk from all causes in psoriatic patients, and it seems to be correlated with the severity of the disease itself, and also increased mortality from specific causes, notably the cardiac disease. In terms of autoimmune diseases, there is higher incidence of inflammatory bowel disease, Crohn's and ulcerative colitis, and also there is potentially a link with multiple sclerosis, as psoriasis is more common in families with MS. Now, another important and often overlooked or neglected aspect is the psychological impact and the quality of life. Psoriasis has an enormous emotional impact on an individual, especially, and it doesn't correlate with the extent of the skin disease. So even few plaques can affect the patient mentally or can cause major disability, whether mental or physical. So patients often have poor self-esteem, sexual dysfunction, to even anxiety, depression, and suicidal ideation. And the prevalence of depression may be as high as 60%. So not just the mental, but also the physical disability. So can cause occupational impairment of function and poor quality of life, especially when it involves areas such as the palms, soles, or the scalp. So this is about the clinical features and the comorbidities associated with psoriasis. So let's take a look at the management. Now, generally speaking, we have this stepwise or stepladder approach, where in mild cases, we start with avoiding triggers, moisturizing, and then we use also topical treatment, topical medicated treatments that we're going to discuss in a few seconds. And then in moderate to severe cases, we move on to phototherapy, if applicable, and systemic biologics, which are the newest kids on the block. So sometimes we go right away to systemic treatment or more aggressive if the presentation is severe from the beginning. Now, topical arsenal that we have includes moisturizers. Never underestimate the role of moisturizers. It can help a lot in reducing scales and reducing itch. But we always definitely have to use some medications or medicated creams. So topical steroids are the first line, and there are different classes on potencies from 1 to 7, from very ultra potent to weak. And then we have some steroid-sparing agents, such as the vitamin D analog, calcipotriene, and vitamin A analogs, tazarotene, and other topical calcineurin inhibitors, such as tacrolimus and pimecrolimus, along with other agents, such as coal tar, anthralin, and salicylic acid. Now, moving on, for more advanced cases or more moderate to severe cases, we need to use phototherapy. The most commonly used is narrowband UVB. It is safe and effective, and it can be full body exposure or localized exposure, such as in palms and soles. Now, moving to systemic treatment, immunosuppressants such as antimetabolites, methotrexate, azathioprine, mycophenolate, or calcineurin inhibitors such as cyclosporin. Oral retinoids are also very good in treating some moderate cases, such as acitretin, and then biologics. And I'm not going to go into details, but as I showed you previously, TNF-alpha, IL-12 and 23, 17 and 23 are the targets of our biologics, and with more advanced research, we have more we can pinpoint more culprits or more pathogenic factors, and we can target those with biologics. Now, I'm going to talk briefly about some of the topical agents, and primarily the first line treatment is corticosteroid, because this is what you're going to mostly use in other specialties other than derm. So the first line is usually the steroid, either alone or combined with vitamin D analogs. And remember, as I said, a steroid is not a steroid is not a steroid. There are different classes from 1 to 7. Some of them are very potent and some of them are very weak. And we need to be familiar with these, but this is beyond our topic, but it's very important to know if we're going to use them. Now, the choice depends on many factors other than these, but the disease severity, the location where it is thin skin, thick skin, or the lesion itself, if it's thin or thick, and the patient's age and the preference and the presence or absence of hair all play a role. So it's usually used twice a day for about 2 to 4 weeks or longer, but you have to be careful with long-term use of steroids. So low potency topical corticosteroids are generally advisable for the face and intertriginous area, so the skin folds, because they're under occlusion and they're thin, so they're more susceptible to the long-term side effects of steroids, as well as infants. So if you're applying to a large body surface area, it's better to use a low potency steroid, especially in infants where they have a high body surface area to weight ratio.
2 minutes. 2 minutes.
Okay. So I'm going to try to speed up. So, so in adults, we use more potent steroids, especially on thick plaques. Hairy areas may require gel solutions, foams, or shampoos. Now, I'm a primary care physician. What can I do for my patient with psoriasis? So explain to him it's not contagious, it's not infectious, so he doesn't have to worry about infecting others. The nature of the disease is chronic, relapsing, and remitting. So he has to understand that it will come and go, and we can control it, but we cannot cure it. It's important to tell him about the triggers so he can avoid it. Avoid piercing, tattoos, and be careful and be aware of that some medications, either starting them or stopping them abruptly, can flare up his psoriasis. And also advise him about lifestyle modification to reduce the risk factors of the associated comorbidities. At each visit, screen for arthritis, screen for the psychological effects and the quality of life, and please help us in addressing the modifiable risk factors for coronary artery disease and metabolic syndrome, and may consider age-appropriate cancer screening. And those are some indications for referral adapted from the NICE guidelines. So if the disease is not clear, or that we are not sure about the diagnosis, or if it's severe, involving more than 10% of the body, or topical treatment is not working, or if you have nail or scalp or any area of psoriasis that's not responding or having a great impact on the person's mental and physical well-being. Acute gut taste psoriasis may require phototherapy. Obviously, the more severe forms, like in the erythroderma and generalized pustular psoriasis, you may refer them to dermatology, preferably to be seen the same day, or send them to emergency, and they're going to consult dermatology, and children, pregnant ladies, and of course, the presence of psoriatic arthritis indication to refer for rheumatologists. Now, I'm an obstetrician, so what are the effects of psoriasis on pregnancy? The outcome most likely will not change. However, there are no links to birth defects or miscarriages, but there is only one study that found there is a low incidence of low birth weight that is increased in mothers with severe form of psoriasis. The major challenge is treating the mother with low-risk medication that doesn't pose any risk on the fetus. Most of the pregnant ladies will improve during pregnancy. In a minority, they will worsen, but those who improve during pregnancy will likely have a postpartum flare. Now, always consult with a dermatologist, but to have an idea, limited disease can be managed with topical moisturizers and low-potency steroids. If it's more advanced, we can treat them with narrowband UVB, but we try to avoid any systemic treatments. There are some that we can use, but we have to judge case by case. Absolutely contraindicated is acitretin, methotrexate, and tazarotene. Now, yes.
Okay. And I think some of the OBGYN or pregnancy-related psoriasis, I think will be part of tomorrow's lectures as well. Just for the sake of time, we have many questions, but I don't think we'll be able to go through them. Actually, Dr. Sahal from the previous lecture was able to go into the question and answer box and answer many of the questions. So we'll see, maybe Dr. Badr can help answer some of those questions in the chat if possible.
Sure.
And we'll move on to our next talk. So it's an absolute pleasure to present Dr. Mohammed Al-Jasser, who is an assistant professor and consultant at King Saud bin Abdulaziz University for Health Sciences in King Abdulaziz Medical City in Riyadh, Saudi Arabia. And he'll actually be talking to you about some of the most important drug eruptions that you need to know about. So without further ado, Dr. Mohammed, the mic is yours.
Hello, greeting everyone. I just want to make sure that everyone sees the slides and hear me properly. Would you kindly confirm?
I do not see the slide yet.
Oh, just a second. How about now?
Okay, yes.
Good. Okay, great. Just play it.
And just to let people know that this lecture will take about 30 minutes, and then we'll have a break after this lecture. So it'll be from 6:30 to 7. We'll have a break time. Go ahead, Dr. Mohammed.
Okay, thank you for the kind introduction, and it's a great pleasure to be invited to give this talk. What I'm going to talk about today is drug reactions that we see in dermatology, and I'll try to make it very simple in order for you to leave the lecture with main points to keep in mind and use it in your practice. So I have no conflict of interest to declare. So in dermatology, drug reactions have many different morphologies, and we diagnose them or suspect the exact diagnosis based on the morphology. So we'll go through that. So the aim of this lecture is to make you somewhat comfortable identifying the specific type of drug reaction based on the way they look when you examine the patient. And in the end, we'll tell you simply what to do. So just the very basics of what to do and how to prevent further reactions. So just made this simple classification. So we'll go through just 2 mild drug reactions, and then we'll spend the majority of the time discussing severe cutaneous adverse drug reactions. We'll talk a little bit about anaphylaxis, but the majority will be about the 3 most serious drug reactions that we see in dermatology. So let's start with the mild ones. So the reason why I included this type of drug reaction, which is called fixed drug eruption, is just because it's not common, but it has a very peculiar way of presentation. So if you're familiar with it, then you're probably going to be able to diagnose it and treat the patient, even yourself. And of course, every time you're not sure about something, you're more than welcome to consult dermatology to confirm your suspicion and get a better advice regarding the diagnosis and management. So fixed drug eruption is called fixed. The name fixed comes from the fact that the rash appears in a specific site, and when the patient is exposed to the same drug again, it reappears in exactly the same site in the future. So that's why it is called fixed. And the morphology of the lesion is characteristically a very well-defined erythematous to dark red or slightly violaceous patch. So very sharply demarcated red to dark red to purple patch. Sometimes when it is very severe, the epidermis gets separated from the dermis and it forms a bulla, a fluid-filled lesion. So initially it is very red. And then when it resolves, it is very common that it leaves prominent hyperpigmentation. So it's just as simple as that. The genitalia, especially the glans penis, is a very characteristic site. So if you see someone with this very sharp red patch on the penis and nowhere else, you immediately ask the patient about if they took any medications recently. And as you can see, this lesion has an erosion. So it was a bulla that ruptured and left behind an erosion, which is a superficial defect in the skin, like Dr. Badr Zamo accurately explained in the first lecture. So this is fixed drug eruption that was red and then started leaving some pigmentation. And the cause in this case was etoricoxib, a COX-2 inhibitor. So the COX-2 inhibitors or non-steroidal anti-inflammatory drugs are a common cause for fixed drug eruption. As I said, the word fixed comes from the rash always recurring in exactly the same site. And in drug eruptions in general, it's important to know when do you expect the development of the rash after the patient takes the medication. So in fixed drug eruption, for the first time exposure, it usually takes 1 to 2 weeks after taking the drug. But with re-exposures, let's say a patient got the drug in the past, got the rash, and then got re-exposed, the patient is already sensitized, so they develop the skin lesions within a much shorter time, within 24 to 48 hours. So that's all of I wanted to mention about fixed drug eruption with regards to the presentation. We'll talk about general management for all drug eruptions at the end of the lecture. The next mild or relatively mild drug eruption, which is the most common type of drug eruption we see, especially in inpatient dermatology, it has one of 3 names. So the name that I will be using is maculopapular drug eruption. And it is synonymous with exanthematous drug eruption and morbilliform drug eruption. So we'll just keep calling it maculopapular drug eruption. So maculopapular drug eruption, as the name implies, it presents with macules and papules. So some flat red lesions and raised red lesions. That is usually generalized all over the body. Initially, they are far apart from each other, but as the rash progresses, they fuse and become confluent. They overlap with each other, like as you see in this patient. So this patient got a maculopapular drug eruption secondary to levofloxacin, and this patient had a maculopapular drug eruption secondary to mycophenolate. So a few words about maculopapular drug eruption. It's the most common type of drug eruption, as I mentioned. And it's a type 4 reaction. It's a delayed type hypersensitivity reaction. So a common misconception that we see among non-dermatologists is that a rash should happen immediately after taking a drug. And that's not usually the case. So it usually takes from 1 to 4 weeks for all drug reactions in general. And there are some exceptions that I will mention. But for maculopapular eruption, focus on medications that were started 1 to 2 weeks before the onset of the rash. So this is very crucial. Knowing the onset, after knowing the duration between taking the medication and the development of the rash is very important in making the accurate diagnosis and identifying the culprit medication. Because for all those types of drug reactions, the most important part in management is to stop that medication and prevent the patient from taking it in the future. So knowing when the medication was started and the exact onset of the rash is crucial. And I will mention that in more detail later in the lecture. Another rule when assessing patients with a drug eruption is to examine mucous membranes, the mouth and genitalia, and also the mucosal part of the eyes, because it is involved in more severe drug reactions. And we will discuss that in those severe drug reactions. In simple maculopapular drug eruption, when you examine mucous membranes, they are intact, and they also don't have any systemic complications. The moment you find systemic complications, then it is another type of severe reaction called DRESS syndrome, most likely, which we will discuss later. So because it doesn't have systemic complication, mucous membranes are intact, we usually treat with systemic treatment, symptomatic treatment. So if they have itching or this rash is very widespread, we give them topical corticosteroids all over. We rarely require systemic corticosteroids, but the main thing is to discontinue the medication. And most of the time we discourage continuing the medication. However, for this type of reaction, if the medication the patient is taking is very crucial for the patient and there are no alternatives, the patient can continue the medication and the rash will improve with time, but it requires close monitoring in the hospital. This is another example of a patient who has a maculopapular drug eruption due to amoxicillin. So antibiotics in general are one of the most common causes for drug reactions in general. So you can see at the periphery, the individual macules and papules, and in the center, they became fused and overlapping, forming large plaques. So those are the two mild skin reactions that I wanted to talk about. So let's move on to some more severe ones. So anaphylaxis is a reaction that most non-dermatologists are familiar with. And the reason why I'm including it here is that it can, in some patients, present with lesions of urticaria. The primary lesions we call, so these lesions that are pale, pink, edematous papules and plaques, we give them two names that are synonymous, either wheals or hives. So they are a useful clue in a patient who presents with anaphylaxis, but more importantly are the systemic features. So different than other types of drug reactions, anaphylaxis is a type 1 IgE-dependent reaction. So it presents within minutes to hours of taking the medications. As I mentioned, it presents with cutaneously with wheals or angioedema. So angioedema is generally a colorless swelling, mainly of the lips or around the eyes. And it is associated, so anaphylaxis is associated with shortness of breath, and tachycardia. That's what makes it very dangerous. And it has a mortality of up to 5%. So it needs to be treated urgently. Of course, discontinuing the drug and labeling it as an allergy is crucial. And the essentials of treatment are supportive treatment in general with antihistamine, corticosteroids, and mainly epinephrine. Very, very important. So sometimes patients present with just urticaria from medications without systemic symptoms of anaphylaxis. So these are wheals or hives due to penicillin. And another just tip for diagnosing wheals or hives. Wheals or hives, individual lesions, do not last more than 24 hours. And sometimes it's confusing on how to determine that. So one tip is to actually mark one lesion with a pen and come back later. Of course, it might not apply to anaphylaxis because you will treat the patient and the hives will resolve immediately or very soon. But for urticaria, if you leave the patient and come back after a few hours, you will see that lesions extended beyond the mark that you have done with your pen. Okay, so these three reactions, DRESS, AGEB, and SJS, TEN, and I'll explain the abbreviations, are the most severe dermatologic drug reactions and considered one of the top emergencies in dermatology. So let's just explain the abbreviations. So I will mention the term DRESS, which means drug reaction with eosinophilia and systemic symptoms. AGEP is acute generalized xanthematous pustulosis. SJS is Stevens-Johnson syndrome, and TEN is toxic epidermal necrolysis. So from now on, I'll use the abbreviations. So DRESS morphology is almost exactly the same as morbilliform drug eruption or maculopapular drug eruption. And I'll explain the differences. So this is a patient who had DRESS syndrome secondary to lamotrigine. So anticonvulsants are one of the top medications that cause drug reactions in general as well. So a few words about DRESS. It's a delayed type hypersensitivity reaction, so type 4. And of all drug reactions, it has the most delayed onset. So the duration between starting a medication and the development of the rash is a bit prolonged. So don't exclude a medication based on the long duration after starting a medication. It can be up to even 8 weeks. So a patient starts a medication and only develops a rash 8 weeks later. So keep that in mind. So as I said, it is very similar in morphology to maculopapular eruption, but it also has cutaneously, it has characteristic facial edema. That's very important in diagnosis. In addition, it has systemic involvement. So they commonly have fever, eosinophilia, lymphadenopathy, involvement of the liver, kidney, lung, and arthritis. So key things, look for facial edema and systemic involvement. And the mortality can range from 5 to 10%. So this is more images of DRESS syndrome. As you can see, it looks very similar to maculopapular drug eruption, but then they have this prominent facial edema. They don't usually have mucous membrane involvement. So there's another example, similar involvement like maculopapular drug eruption, but again with facial involvement. And there is very little to no mucosal involvement. So that's the morphology of DRESS syndrome that I want you to know. What to do with regards to the management, we'll discuss later. The second severe drug reaction is AGEP. So AGEP is characterized simply by diffuse erythema, and within this erythema, there are numerous tiny pustules. That's it. So that's the main characteristic. Again, diffuse erythema with multiple numerous tiny pustules on top of this erythema. It's another example. Background of erythema with multiple tiny pustules. That's AGEP. And in this patient, it was due to rivaroxaban. This is AGEP due to amoxicillin. Again, you see diffuse erythema with multiple tiny pustules. And in AGEP, it is common or characteristic to have accentuation in the flexural areas. Another example, AGEP due to cephalosporin, diffuse erythema with multiple tiny pustules. So as simple as that. Okay, so a few words to keep in mind. So it's a rare reaction, it's a type 4 reaction, but the exception here as compared to other rashes, it doesn't have to be the medications doesn't have to have been started more than a week. It can develop it usually develops within 4 days of starting a medication. So keep this in mind. If you see this morphology, keep this piece of information in mind with regards to the timeline between starting the medication and the development of the rash. As I said, there are numerous tiny pustules on a red base. The patients present with high fever and high white blood cell count. Mortality is 1 to 2%. Again, you have to discontinue the medication, and usually topical corticosteroids are enough. So stopping the drug and topical corticosteroids are enough. It is very rare to require systemic corticosteroids. And this is the final reaction, the most severe one. The difference here, you can actually see that the spots are a bit darker red in color. And in addition, you see open areas, you see erosions. So if you see that, you immediately examine the mucous membranes. And these patients have very severe mucous membrane involvement. That's very characteristic for this type of reaction. And this reaction has very high mortality. So you really have to have a high index of suspicion and consult dermatology immediately. So this is SJS-TEN. So SJS is called when the body surface area of involvement is less than 10%. TEN is called when the body surface area is more than 30%. If the body surface area is 10 to 30%, then it is called SJS-TEN overlap. But they all have similar presentation. This patient had SJS due to carbamazepine. Okay, this is another patient with SJS-TEN, and here you can see again the dark red patches, and this is due to epidermal necrosis. This drug reaction is associated with severe epidermal necrosis. And one of the characteristic things, if you press on your skin, on intact skin, this pressure causes sloughing of the skin, and this is called Nikolsky sign. It's a very characteristic sign for SJS-TEN. And again, this patient had very severe mucous membrane involvement. So the patient had this rash due to lamotrigine. Another patient who had rash due to phenytoin, you see those dark red to brown patches. You also see Nikolsky sign with separation of the epidermis from pressure. And also additionally from the severe reaction and epidermal necrosis, sometimes you see intact bullae. So dark red areas, skin sloughing with pressure from epidermal necrosis, and sometimes bullae. This is a patient with severe TN. You see sloughing already of most of the body parts. So this is a very real emergency. And again, very severe oral erosions. This patient had a reaction due to diltiazem. This patient has TEN, see very widespread sloughing of the skin with respiratory compromise. Due to that, patient needs admission to ICU for that. So a few words, important things. So it's a rare syndrome, but very life-threatening. And the main thing that happens is epidermal necrosis. So there is skin sloughing and sloughing of the mucous membrane, so mucosal erosions. Because of that, they also get fever, electrolyte imbalance, respiratory distress, and eventually they might get mucosal scars. So multidisciplinary action and getting other teams involved is very important. Mortality can be up to 35%, and it's mainly due to infection. So admitting the patient to ICU, or even better to a burn unit, you consider this as a burn case and get burn treatment. It's very important for the management of this condition. Okay, so this is an overview of what to do of how to recognize the reactions, but what to do. So ensuring the correct diagnosis is very important. It's very important to discontinue drug early. And as I mentioned, the timeline is 1 to 4 weeks with some exceptions. The most common medications are antibiotics, anticonvulsants, sulfonamides, allopurinol, and non-steroidal anti-inflammatory drugs. To determine the culprit medication, it's very important to make a drug chart. So you put the list of medication of the patient and the timeline of each medication and compare it with the onset of the rash. So here, the timeline of ciprofloxacin and vancomycin makes us suspect these two. So when this is the case, it's very difficult to determine which one is the culprit. So looking at some drug databases like this Let's Drug Eruption and Reaction database might help you determine which one is the more likely culprit, but sometimes it's difficult. So for example, here we put a reaction in Johnson syndrome. And then we put all the list of medications, and we found that allopurinol has the most number of reports. So this makes it the likely culprit. Sometimes some tests can help in diagnosis. It's only helpful in urticaria after the rash resolves, but in other reactions is not that practical usually. So patch testing can be done, and some research-based in vitro testing like lymphocyte transformation test. As I mentioned, symptomatic treatment is important for some reactions. Topical steroids is the only thing that is needed after stopping the medication. Stopping the medication is very important. So topical steroids is needed for AGIP only. In DRESS, most of the time you will need systemic corticosteroids. Supportive treatment is important for severe drug reactions, but mainly for SJS-TEN, so admission to ICU and the burn unit. Systemic corticosteroids can be used in all of the severe drug reactions mainly, but mainly in DRESS syndrome, and it's controversial in SJS-TEN. In SJS-TEN, the main drugs that are used, but the most important is stopping the drug and ICU admission. But to suppress the inflammation, use either IVIG, cyclosporin, or etanercept. How to prevent it? Proper documentation and patient counseling about the allergy. No rechallenge. Rechallenge is contraindication. The exception is probably fixed drug eruption. Avoid drugs with cross-reactivity. HLA screening might be helpful. We don't have that here. But the FDA, for example, recommends genetic screening of HLA-B1502 prior to the use of carbamazepine for Asian patients. So take-home messages. Severe cutaneous adverse drug reaction, the most severe is SJS-TEN, then DRESS, then AGEP. SJS-TEN presents with necrosis, sloughing of the skin and mucous membranes. DRESS presents with generalized red spots with systemic symptoms. AGEP presents with numerous small pustules on red base. What to do? Discontinue the medication, make a drug chart, very important, supportive treatment and immunosuppressives. And how to prevent it? By proper reporting of the allergy and avoid chemically related drugs, and also HLA screening if possible. So that's it. I'll be happy to take any questions.
Thank you, Dr. Muhammad. As always, very informative talks. I always enjoy them. So thank you so much for accepting the invitation and to give this great talk. So yes, we do have yeah, so we do have a few questions.
Shall I just stop sharing the screen or just leave it?
I think it's fine. You don't need to worry about that. I'm just going to ask you a few questions that we got. First of all, can AGEP occur in the pediatric age group?
It can happen in any age group.
Okay. So can we do a drug challenge to determine which drug is a culprit, or will this risk more severe reactions?
Yeah, the drug challenge is a big no. Re-challenge, because then you might induce the severe reaction again. As I mentioned, the only exception is in fixed drug eruption, because it's limited to small areas and it helps in the diagnosis. But again, sometimes fixed drug eruption can be very severe and generalized. So you have to be very cautious, and re-challenge should be always discussed with allergists and or dermatologists. But most of the time we don't re-challenge.
So there's one more question here about if you can briefly talk about how to differentiate between erythema multiforme major and SJS.
So erythema multiforme major and SJS, that's a very good question. Sometimes it can be challenging to differentiate, but SJS-TEN is mainly due to a medication. So if you have a medication that gave you a picture that you think is erythema multiforme major, then probably consider it SJS and be in the safe side. The other thing is that with erythema multiforme major, you will see more of typical target lesions. So 3 concentric circles, an outer red circle, intermediate pale zone, and then an outer central red area.
Okay, so we have, okay, we still have 2 minutes. I see very good questions here. One question, I think, from a family care physician or primary care physician asking if we should refer DRESS or AGEP patients in a primary care setting.
If you have a patient we suspect DRESS or SJS syndrome in a primary care setting, you have to send emergency immediately. That's very crucial. Be referred to the. You should not contact the dermatologist directly. They should be sent to emergency immediately. And from there, they will deal with the supportive initial measures and consult dermatology immediately. So if there is one take-home message, if you suspect, the reason why I presented this is for you to recognize those rashes and know that you're dealing with a severe one, and have a very low threshold to refer the patient to emergency. That's very important.
Okay. Okay, so another good question. Can a patient have a drug reaction to a medication that he used to take regularly in the past, I guess?
That's a very good question. It depends. So if the patient had it for a few days, then it might pass without causing anything, and the patient gets sensitized to it. So it was only a period, a few days, then you would not exclude this medication. You have to be very cautious because, as I said, they develop the reaction after at least 1 week. So that's one point. The second thing that makes it unlikely for a patient to develop one of the reactions that we have mentioned, if he did not have it in the past and was on a medication for a long time, is that most of those patients are actually genetically susceptible to the reaction. Sorry, I didn't get the chance to talk about HLA, but these HLA types are associated with specific drug reactions to specific medications in certain patients. So they are, since birth, they are prone to get this reaction to this particular medication. That's why for carbamazepine, all Asian patients should be screened as a requirement by FDA for HLA-B1502. If they have this HLA type, then the carbamazepine is contraindicated. I hope this answers the question.
Excellent. Let's take the last one. Just a very interesting question. Could isotretinoin cause Stevens-Johnson syndrome?
To be honest, any medication can cause Stevens-Johnson syndrome. If you look at reports, even while I'm using this app, the Let's app, and by the way, I don't have any conflict of interest. I just purchased this app because it's the only one I know. And sometimes I get stuck when I see patients. I see 3 medications that were started around the same time, and they are all potentially culprits. So I cannot memorize everything. So why am I mentioning all of this? If you have, for example, isotretinoin, and you do the timeline, and it fits within the timeline that is expected for a drug reaction, and there are no other medications that are more likely to cause a drug reaction, then it can be a culprit. There are several case reports of reactions that were only reported once, but the timeline fits very well. So because the consequences of continuing isotretinoin, even if it's not the culprit, are more harmful than discontinuing it if you're not sure. So never hesitate in stopping any medication, but of course, after very thorough assessment. And please remember to look at the timeline of medications and make a detailed drug chart. This is the single most important part of assessing a patient with a drug reaction, because remember, what's the most important step is to stop the medication. If you don't do a detailed drug chart, then you might miss a very dangerous medication. For example, the patient who had a reaction to diltiazem. Diltiazem is not a common medication, but after doing a very detailed drug chart, in this patient who had toxic epidermal necrolysis, it was very clear that this was the medication, and we labeled her allergic to it. Otherwise, she would have been continued on that and she would have died because the reaction will continue. So please do a detailed drug reaction assessment. And sometimes during my on-calls, I spend like an hour or an hour and a half in patients who are on multiple medications. Because you know what? By doing this, you'll save the life of the patient if you pinpoint the medication. But unfortunately, we don't have a quick blood test that tell us which medication is the culprit. I wish we get that in the future because it will help us a lot. But for now, focus on doing a very detailed drug chart. This is the only solution now.
Excellent, Dr. Mohammed. And I always talk to my residents, and I always tell them that you need to do a literature review. Every time you suspect anything, you need to do a literature review. You might find something that was reported a week ago about a new medicine that caused a certain...
Absolutely. So what I do is I actually first look at all the medication and pinpoint those few medications that are likely to be culprits. So let's say there are 3 started around the same time. But then, as you said, we get stuck. Okay, which one of them is the culprit? Because timeline fits with all of them. Then, even if some of them are rare, then we have to do a literature search or use this application, for example, and try to figure out. Sometimes it's hard. Even if you do all this work, it's really tough. And before every on-call, I actually give my residents a drug chart and show them. Imagine, before every on-call, this is the first thing I teach them. Please make a drug chart for every patient you suspect to have a drug reaction, because it takes a lot of time and effort to do, and it is important. And there is no other way around it, unfortunately.
Excellent. Thank you so much, Dr. Mohammed, for answering these questions and for your talk. So for now, we are going into our first break. So we'll be back at 7 o'clock, 7 p.m. And we have 2 more lectures for today. And we have a full day tomorrow. So please let us see you back at 7 o'clock to start our next talk.
Thank you very much. Much appreciated.
Assalamu alaikum. Good evening, everyone, and welcome back. I hope you were refreshed and stretched during the break time. My name is Dr. Dermatology, and I'll be moderating the remaining sessions to come. Our next speaker is a consultant dermatologist at East Jeddah Hospital. Dr. Lu'ay Salah will tell us all about lumps and bumps in dermatology. So without further ado, Dr. Lu'ay.
Hello, everyone. Thank you. Can you hear me?
Yes, we can.
Perfect. So what I'll be talking about today, lumps and bumps. First of all, thank you very much for your attendance. This might be the biggest audience. It is the biggest audience I've ever lectured to. Your interaction is amazing, and I love this course. So my lecture today is a very important one. And I'm not saying that because I'm giving it, no, because by this lecture, you might be able, by the end of it, to help someone to save lives. And this might be the biggest comeback of dermatologists to other specialties who claim that we don't save lives. We do save lives, and I will prove it in this lecture. So we'll be going through some benign and common skin lesions. And I don't want you to go deep. I don't want you to know how to manage each one. What I want you to know is if you get a bumpy lesion, to tell initially if it's benign or malignant, if it deserves to be referred to a dermatologist or not. So let's go on and take this one, for example. You have 2 similar lesions, but can you tell which one is benign and which one is malignant? I personally cannot tell. But actually, one of these are skin cancer, and the other one is a benign lesion. And you can tell from the look of it. What you need, first of all, is a good history and a dermoscopy or a magnifying lamp to see some patterns. And I'm going to be talking much about it. But what are the questions that are important to ask to tell if this bump is benign or if it is malignant? These are the important questions. How long has it been present? Did it start yesterday or did it start 10 years ago? It makes a big difference. And then the history of change, how has it changed? If it changed in size, if it changed in shape, if it's changed in color. And history of itching and bleeding is less important, but it has to be there. So imagine yourself in the clinic, and I'll be going through some cases. And I'll show you a lot of pictures, and it's gonna be interactive. So I expect your interaction and your answers in some of these cases. Let's take case number 1. You have this lesion. Suha, she's a 42-year-old female that comes to you with a new mole in her chest, and she's asking you, doctor, do I have a skin cancer? This is one of the most common questions that you get in a cancer clinic. Is it skin cancer or not? What are you gonna do? First of all, you're going to ask the questions that we presented before. How long has it been present? 2 years. It was noticed by her husband. There is no change in shape, size, or color. And if we use our dermoscopy, our magnifying lamp, we will see this pattern. Look closely and tell me, what do you think? Is this one an nevus? Is it a melanoma? Is it a seborrheic keratosis? Or is it a wart? I don't expect you to get the right answer right now, but at least to try. Just tell me from the history. We started with an easy one. So is it a good one or a bad one? So what do you think? So I don't know if I can see the result, but this one is actually a seborrheic keratosis, a benign lesion, a good bump. It doesn't need to be referred to dermatologist. It doesn't need to be excised. So what are seborrheic keratosis exactly? They are harmless, superficial epidermal growths. So like most of you thought it was melanoma, and it's okay. You're not dermatologist, and I'm not expecting you to know it right now, but by the end of it, you will know all of these, inshallah. So these are harmless superficial epidermal growth. They can arise anywhere in the body except the palmar soles. It is usually associated with skin aging. So you don't see it in infants, you don't see it in newborn, you see it in older individuals, 30 years onwards. And the difference between these and nevi appear early in life, or moles or habat al-khal, we see them early in life. These appear late. And if we look in a patient, you can see many of these, not only one. You can see a lot of these. And they have very characteristic, we call it stuck on quality. It's like they're stuck on the skin. They're very superficial. And even with shaving, you can remove it easily. If we use our dermoscope, we will see a very characteristic pattern. You see these yellow circles. These are called axis. They look, it's merely like, look at the brown ones, the brown circles, they're called comedulite openings. So if you see these two, it is probably, most likely, a seborrheic keratosis. You can see it very clearly here, the milial axis. Here you can see the other on the right, on your right-hand side, the comedulite opening. So do we need to treat them? We don't have to, but you can treat them with any ablative treatment. You can treat them with cure, like shaving it. You can with nitrogen, spraying it. You can treat them even with electricity or shaving. So they're benign, they're good. Moving on to the next one. What are these? You get this patient, which is a famous actor that you all know, I'm sure. And he's asking you, doctor, can you remove these freckles? First of all, are these freckles? No, they're not. This is actually a variant of seborrheic keratosis. And these are very benign. We see them in older individuals, and we see them in darker skin. They look like hyperpigmented, sessile, filiform, like with a stalk, smooth surface papules. If you remember from the first lecture, papules are small elevated lesions. And we mostly see them in darker skin types on the cheeks and temples. So you have different pictures of dermatosis papulosis nigra. When it comes to treatment, it could be treated with any ablative therapy, like we discussed, including laser. We can treat them with cryotherapy, although I don't recommend this in darker skinned individuals. And we can treat them also with electrodesiccation, both settings. This is one of the studies that showed successful removal of these. So moving on to the case 3, are you following on so far? Are you is it going good? Great. So you give this one, he has moles on his necklace and he wants to remove them. You see them up there up. So what do you think? These are called skin tags, skin colored papules. They can appear on the eyelid, neck, axilla. I'm sure some of you have seen it. Some of you even have it on their skin. They're asymptomatic. Sometimes they can become painful, secondary to irritation or infarction. Why do we get these? Genetics, our genes. Obesity can be a cause. Pregnancy, they can arise in pregnancy, and friction. That's why we get them on the neck, on the eyelid, because there is a lot of friction there. Should they be removed? They can be removed also with any ablative therapy. You can even clip them, you can cut them, you can even tie them with any string and leave them and they will fall off. So is this any similar? Does it look familiar to you? Is it acne? Actually, it is not. These are called milia. It's like they're small subepidermal papules. They're usually fixed. They appear on the cheeks, mostly under the eye, above the eye. They can occur in any age, but mostly we can see it in infants. And in infants, it's self-limited. It usually goes away after the first 4 weeks, but we also see it in adults, and they can be secondary to trauma, skin disease, or meds. And when it comes in adults, it's usually chronic. And it could be treated. Yes, it could be treated with the needle. Just stick a needle in it, an 18 gauge syringe, for example, stick it, and you just extract the material, and that's it. Easy to treat, very common, but important to recognize because they don't usually go or disappear with acne creams. So moving on to case 4. You have a Khalid who has a nevus on his face that he is concerned about. Okay, this is not Khalid, but when I Googled the concerned look on Google, this is the first image that I got, and he looks really concerned. So you're asking the same questions. How long has it been present? As long as he can remember. Any change in size, shape, color? Nope. Does it itch? No. Has it been bleeding? No. And this is how it looks like. And if we go back to the first lecture, we can describe it as a papule, a brown papule. It is a dome shape because it looks like a dome. It is symmetric. It's 8 millimeters in size and sharp borders. So what do you guys think? Is it a nevus, a mole? Is it a melanoma? Or is it a seborrheic keratosis? First and third one are good ones. The one in the middle is a bad one. So can we get the poll here, please? Maybe I'm going too fast for the poll. So anyway, if you don't see the polls, okay, just try to think, guess a diagnosis in your mind, and let's see if it works. This one is a nevus. Why is it a nevus? You have a history of that is not changing, and it looks like a nevus. Now we're getting it. It's too late. But anyway, so these are all nevi, but they look different in color, right? They look different in color. Sometimes they can look different in shapes because when we get needles, nevi, first in life, they look macular. They're more flat. They're brown in color, but with time they become elevated. Same color, brown, and then they start losing color. So it's important when we see any nevus, any mole, that we ask ourselves, and we go by the ABCD rule. You got it, nevus, right? Because I told you. So we have to ask ourselves the ABCDE rule. This is one of the simplest ones and important ones. If you get any nevus, you have to ask yourself, is it A, symmetrical or asymmetrical? Asymmetry is not good. Symmetry is good, which means, is it a mirror image? If you fold it over itself, is it going to be a mirror image of itself? Are the borders regular or irregular? Do we have different colors in any of it? The more colors we have, the more suspicious it is. And the diameter, we usually detect melanoma and skin cancer when it's larger than 6 millimeters in size. And the most important one is the last one, E, which stands for evolution, change in size, change in shape, change in color. So let's look at different ones. Here we see a very good example of asymmetry. The upper half is not symmetrical to the other half. It's not an mirror image of the second half. We see the other one, irregular borders. They're scalloped, they're not regular. The third one, we see different colors. This is not good. The more colors we see, the more suspicious it is. And the other one is a big one. So usually, if it's a big one, it's suspicious. And as I said, evolution. You see this lesion on the base. You see how it's changing, evolving, changing in size, getting bigger and bigger and bigger. So you should suspect malignancy if you see any of these signs or all of them together. Let's look at this one. Is this symmetrical or asymmetrical? Just say it out loud. I'm not going to hear it, but just say it. This is symmetrical. Yes. What about this one? This is definitely asymmetrical. What about the other one? This one. Is it symmetrical or asymmetrical? Is it a mirror image? Yes, more or less, it is symmetrical. So symmetrical is good, asymmetrical is not good. What about this one? This is definitely asymmetrical, right? And even the borders, you have every single sign. Asymmetry, you have border irregularity, you have different colors, you have a big diameter. And I'm sure if you ask this patient, he will admit that this lesion is changing fast. And this is not good. Moving on to case 5. Are you keeping up so far? I hope you are. So Ahmed, you have a 50-year-old. This is a long history because it is important. He has a lesion at the mole on his back and he can't see it. But his wife asks him about it and she thinks it has changed. And I tell you from experience with patients, usually the wife is right. So past medical history, he usually burns, he rarely tans, that makes him Fitzpatrick skin type 2, which is a white skin. It's important, I'll tell you why in a bit. Sunbathed, he used tanning booths as a teen. He look at this family history. His brother had a melanoma. Social history, he works as a security guard at the local mall. Is it important? Yes, because he's staying outside for long periods of time. And this is his lesion. So if we take the ABCDE rule, doesn't look okay, right? Not at all. So we took out the lesion, excisional biopsy, and we see in the histopathology. I'm sure you're not an expert histopathologist, but you see the lesion it is asymmetrical. And if we look at the melanocytes here that are grouped in nest, we will see signs of atypia. Nuclear looks weird, differently. This is actually a melanoma. And let's skip the polling here. The melanoma is a very bad bump, okay? This is deadly. This can kill people if you don't detect it early, and it grows fast. It originates from the melanocytes, and it is the deadliest form of skin cancer and the most common skin cancer among young women between the 25 and 20 years of age. In our skin type, we don't usually get a lot of melanoma. We don't see a lot of melanoma here in Saudi, but when I used to live in Sweden, I saw a lot of melanoma because of the white skin. That melanoma that we get here actually is different than the melanoma we have it. You have it on light skin colored. But we are seeing a higher prevalence of melanoma with time. Why is that? Because of the risk factors. Increasing age, also fair skin. If you have blue eye, red, blonde hair, this is a risk factor. If you have greater than 25 acquired nevi, this is another risk factor. Atypical nevi is a risk factor. Immunosuppression. And most importantly, if you have a personal history of melanoma or a family history of melanoma. So sun plays a major role. If you have a blistering sunburns before puberty, this is a major role in melanoma. But when it comes to our skin color, is the sun most important factor? Not really, because the type of melanoma that we usually get is usually this one, the acral melanoma on the periphery, on the hands, we can see it, on the feet. And this is not proven to be sun-related. But when we talk about other types, like the superficial spreading melanoma, like amelanotic melanoma, like the nodular melanoma, then sun, then when we talk about lentigo malignant melanoma, this sun plays a very, very, very major role. Okay, this is a nodular melanoma. This is a bad melanoma because nodular melanoma, when it grows, this type, it grows vertically. So it goes deeper in the skin. So it invades the tissue, the deeper tissue faster, and it can grow to the lymph nodes and metastasize very quick. And these are different types. You can see these are all acral melanoma. This is the type of melanoma that you should be alert to, because this is the most common type in our skin type, the Middle Eastern skin type. And I'm showing you this because I'm telling you, if you have detected early, you will save lives. The 5-year survival rate can drop significantly if it's detected late. Okay. How to treat excision is the best way of treatment with wide margins. I'm not going to delve deep into that because it's not a dermatology lecture, it's a general lecture. So we'll skip that, but excise the melanoma. Sometimes you need to do the sentinel lymph node if you have a thick melanoma ulcerated. Radiation therapy, not really done. We use it in desmoplastic melanoma or metastatic disease. Now we have a picture of a swimmer. Why am I showing you this? Because this swimmer has a history behind him. If you look closely, this is a recent picture, not a recent, it's a recent relative to this one. This is an older picture of him, and this is the recent one. We go back and forth and try to detect what's different. It's this one. This is a changing nevus. He's this swimmer, he's an Australian swimmer that won the Middle Olympics, but he had a nevus that was changing, and he was alerted by an anonymous fan. An anonymous fan sent him an email, and he told him to check on this mole. And it actually proven to be a bad bump, precursor for melanoma in situ. And he actually excited, and he thanked the anonymous fan, and it was actually published. It was written everywhere at that time. So I want you all to be like this anonymous fan, to detect skin cancers as early as possible. So moving on to the case number 6. We're going fast. Hope you're catching up. So this is Erica. She's a 62-year-old woman who presents to your office with a skin growth by her right ear. You can see it clearly here. It has grown in 6 months. It's increasing in size. If we use our dermoscopy, we will see these arborizing vessels, these telangiectasia. This is important because this is the biopsy. And we can see in the biopsy that the basal keratinocytes, these are the basal keratinocytes, this is a normal histology. We can see there's a collection of basal keratinocytes that are growing inward. This is a tumor. But what it is. So let's do some real polls now. I'll wait. Option A, basal cell carcinoma. Option B, malignant melanoma. Option C, wart. Option D, seborrheic keratosis. Or option E, squamous cell carcinoma. What do you think? So we'll wait and see what do you think of this tumor. I went fast on it, so it might not be that clear for you, but it's a growing tumor for 6 months on the face, and it's showing some characteristic dermoscopic images. So let's see what the polling result is. So most of you thought it was a basal cell carcinoma, 44%, while 27% thought it's a squamous cell carcinoma, which are good, 2 good guesses actually. Yes, this one is actually a basal cell carcinoma. So what is a basal cell carcinoma? It's from the name. It arises from the basal keratinocytes in the epidermis from here. And it's the most common skin cancer. It's very common. Sometimes you get a patient with 5 or 6 basal cell carcinoma at the same time. And why do they get these? It's because of the sun. It causes a mutation in the PTCH, patch tumor suppressing gene, and it could be spontaneous or acquired. So the risk factors are the same for all the tumors, mostly. Increasing age, skin type 1 or 2, severe actinic damage, sun damage, immunosuppressions, and some genetic conditions. And if we use our magnifying glass, that's why I'm stressing on the dermoscopy in these. If you're not a dermatologist, you don't need to have to get it. But if you're planning to become a dermatologist, if you're planning to become better at diagnosing tumors, even inflammatory skin conditions, you need to get a dermoscope. And you will see some of these. You will see some telangiectasia. These are linear telangiectasia, we call it arborizing vessels. And even some pigmentation that we call it ash leaf spots. For example, this one. This is a red plaque. It could be anything. It could be dermatitis. It could be psoriasis. It could be eczema. It could be anything. But if we use our dermoscopy, we will see these arborizing vessels and some pigmentation that are characteristic of basal cell carcinoma. That's why dermoscopy is important. And even dermoscopy is important to detect the periphery, to detect the margins of the lesion. Like in this one, if we use a dermoscopy here, we will see that the margins of the lesions are there. I don't know if you see my error, but I'm showing you the margins of the skin cancer. So the most common type is the nodular BCC. There are different types, like the pigmented BCC. This is most common in our skin type, in the darker skin type. And you will see the pigmentation. You don't see a reticular network like what you see in melanoma. What you see here is a more of a, like a ash leaf spots, some pigmentation. And let's look at these different tumors. Which one of these is a BCC? From a clinical picture. Is it the one on the left? Is it the one on the middle? Or is it the one on the right? What do you think? You can't really tell, right? Let's use our dermoscopes. So the one on the left, we see some telangiectasia here. We see some pigmentation. This is a basal cell carcinoma. What about the other one? We see another telangiectasia and some pigmentation. This is another basal cell carcinoma. Third one, some pigmentation and some visible telangiectasia, arborizing vessels there. So these are all basal cell carcinoma. Treatment of basal cell is easy. You can remove it with a curette desiccation with cryosurgery or excise it with a small margin, like 3 to 4 millimeter. Most microscopic surgery that I'm going to discuss today is reserved for basal cell carcinoma, morphiform basal cell carcinoma, and basal cell carcinoma in difficult sites, like the face. We can use non-surgical options for superficial BCC, like photodynamic therapy, like 5-fluorouracil cream, and Imiquimod cream. So moving on to our third bump. This is Khalid, 70-year-old. He has a bump. You can see it. It's increasing in size. It's from the description, it's well circumscribed, erythematous nodule, central ulceration, and you can see with the dermoscope, you can see the crust here. So this is the biopsy. We can see a well-differentiated keratinocytes. So this is a squamous cell carcinoma. It's a bad bump, and the origin of squamous cell carcinoma is the keratinocytes. You have a high risk of metastasis, not as high as malignant melanoma, and less serious than more serious than superficial basal cell carcinoma. And the etiology, it's usually the same. Sun exposure. Treatment, surgical treatment option is the number one here with appropriate margins. Curettage and electrodesiccation is reserved for precursors, and non-surgical options are also there for precursors or bound disease. So we have two different bumps, right? So are they the same? They're both good bumps, but they're not the same. The one on the right is epidermal inclusion cyst, or we call it sebaceous cyst. It's mobile dermal with overlying punctum. Dr. Badr Zammu touch on it, and it can get inflamed, and you can sometimes squeeze the material out of it. It's smelly material. Definite treatment is the removal of the whole capsule. Okay, incision and drainage, interlesion steroids is the treatment if it gets inflamed. The other one is lipoma that I'm sure most of you are familiar with. It's deeper, it's collection of fat, a rubbery, mobile subcutaneous nodule. It grows slowly and then it stops. Surgical removal is elective. My last point, the campaign that has been going on about being sun smart, because sun is the most important factor in all of our skin cancer. So we need to know how to educate our patients. First one, applying broad spectrum sunscreen, water resistant is important with an SPF 3 or above or more, wearing protective clothing and seeking shade. They have to seek shade. Use extra caution near water and snow because they reflect the rays of the sun. Get vitamin D safely. Don't try to get it from the sun because there is no safe way. Take it from me, there is no safe way to get vitamin D from the sun, and avoid tanning beds. Tanning beds are carcinogenic. They are prohibited. They considered illegal in Brazil, in Australia, in a lot of countries because of the link to skin cancer. There is no, it's proven, okay? And that's it. That is my lecture. Thank you for your attendance, for listening. And I don't know if we have time to take some questions, but I will try to also answer all of them in the chat box.
Very much, Dr. Very informative. I think we have a second to take a couple of questions. The first question is, how can we differentiate between a red nevus and a hemangioma?
A red nevus?
And a hemangioma.
A hemangioma. You mean a hemangioma in infants?
Yes.
So you have a hemangioma in infants that usually starts after birth. It grows, it has a growth cycle, so it becomes bigger in the first 6 months, and then it becomes smaller with time. We don't usually see nevi in children, in infants. We usually see spix nevi or Reed's nevus, which looks like more of a papule. It doesn't become bigger with time. It can become bigger, but it's slowly with time. So it's a different age group.
Thank you very much. One more question. This is divided into two parts. What are the causes of secondary melia, and how do we differentiate between acne and melia?
Differentiating the causes of melia. Sun exposure can play an important role. Genetics is another one. The type of skin is another one. We don't really know the exact cause, but we see it in people. The differentiation with acne, you can see open comedones, closed comedones. It looks and it feels differently. It improves with topical creams, with topical retinoid. Melia usually doesn't improve. It's much deeper and it needs surgical removal. And it's around the eyes. Acne can happen anywhere on the face. And it's associated with more oily skin.
Great. Thank you very much for your talk. Very informative.
Thank you.
All right. Our next speaker is a consultant dermatologist at National Guard Hospital. She also specializes in autoimmune connective tissue disorders and autoimmune diseases. Dr. Abir Sarhid is going to talk about the most important infections you need to be in the lookout for. So without further ado, Dr. Abir, take the lead, please.
Sorry for the delay. Just a second. I'll open my presentation. I'm not sure how to do that. Okay. Can you hear me well?
Yes, we can hear you clearly.
And you can see my slides as well?
Nope, not yet.
Not yet. Okay. So, can you see it now? Because someone is like moving the slides. I'm not sure.
No, we can see you and hear you, but we cannot see the slides.
Okay, just a sec.
Sure, take your time. Okay, the slides are out.
Okay, perfect. Okay, thank you for the invite. So it's my pleasure today to speak to you today about common infectious skin diseases. So hopefully by the end of my talk, you'll be able to recognize common skin infections. I'll only focus on the common ones that are encountered in primary care setting, and we also gain knowledge of the different diagnostic modalities used in these to establish diagnosis of these infections, and finally be familiar with different treatment modalities. So let's get started with our first case. So I was consulted to see this patient who had a flap removed from the forearm, and surgery was done 2 months ago. He was then prescribed neomycin and dressing for almost 2 months. 2 weeks into post-surgery, he developed this itchy erythematous lichenified plaque, and that is well demarcated, as you can see here. So given the morphology of it, our diagnosis was allergic contact dermatitis secondary to neomycin. Neomycin is one of the top 10 allergens in the world. And as you can see here, there is this yellow colored crusting here. So this indicates secondary impetigonization. So what is impetigo? So impetigo is one of the most common bacterial superficial skin infections. And there's 2 clinical subtypes, the non-bullous and the bullous impetigo. The non-bullous is the more common one. It accounts for almost 70% of all cases, usually, as the name implies, non-bullous. So they start as pustules that rapidly ruptures into erosions with honey-colored crusting. Usually the most common location is periorificial, meaning around the nose, around the mouth, and also on the extremities. The most common etiology is Staph aureus. Less often strep pyogen or group A strep is implicated. On the other hand, bullous impetigo accounts for only 30% of cases. Here, Staph aureus, specific subtype of Staph aureus that produces exfoliative toxin A and B, is implicated in etiology. So this toxin would result in a split higher up in the epidermis, resulting in a flaccid blister, as you can see here in the photo. And the most common location is usually flexors as well as the trunk. So the complications associated with each subtype is different. So patients with non-bullous impetigo that is caused by strep pyogen, almost 5% of those patients can develop acute post-streptococcal glomerulonephritis. And as you know, those cases, oral antibiotic therapy does not prevent the development of glomerulonephritis. On the other hand, most experts believe that impetigo is not associated with acute rheumatic fever. However, this is still controversial. There are still studies that support a positive association. And here, antibiotic therapy can decrease the risk of acute rheumatic fever, as you know. On the other hand, bullous impetigo that is caused by this exfoliative toxin producing Staph aureus, if this toxin would spread in the blood, okay, such as in someone who has immune impairment, okay, such as a neonate or an adult with immune deficiency or a renal failure, this can cause staph scalded skin syndrome. So how do we establish the diagnosis? So the diagnosis can be clear clinically if you see honey-colored crusting, whether on normal appearing skin or on skin that is affected by, for example, by eczema, like in our first case. Think about impetigo, whereas maybe in bullous impetigo, it's not that straightforward. If you're suspecting it, you can do a culture for gram stain and a bacterial culture that will establish the diagnosis, including defining the organism and antibiotic susceptibility. So if lesions, as always in dermatology, if there are few lesions, this is amenable to topical therapy. Fusidic acid can be given because it would cover a majority of cases, especially methicillin sensitive staph. However, if someone is MRSA carrier, then you should prescribe mupirocin ointment because MRSA usually is resistant to fusidic acid topically. If the lesions are multiple or if there are associated complications, then an oral antibiotic is warranted. You can start a first generation cephalosporin like cephalexin or dicloxacillin. This would take care of methicillin sensitive staph as well as strep pyogen. If penicillin allergic, as you know, macrolides or clindamycin can be given. On the other hand, if someone is colonized by MRSA, then you need the oral antibiotic should cover community acquired MRSA even before having the final result of wound culture that would take 2 days. So in these patients, you would select more like either doxycycline, clindamycin, sulfa, trimethoprim, or other oral antibiotics in more resistant cases. And if someone has recurrent bacterial skin infections, including recurrent impetigo or folliculitis, remember they can be carriers of Staph aureus. They can carry the bacteria in the nose, axilla, groin area, or the web space. Therefore, eradication might be helpful in decreasing the recurrence rate. So how do you eradicate staph? By prescribing mupirocin ointment, BID, to the nostril for 10 days, or mupirocin cream for 10 days to the flexural areas. You also add chlorhexidine body wash daily for 2 weeks, or an alternative simple thing that can be done at home is the dilute bleach bath that is also used in atopic dermatitis. And finally, you ask the patient to sterilize the commonly used fomites, such as computer, mobile, with alcohol wipes. This regimen can decrease the recurrence rate of recurrent staph infections. So our second case, so this 20-year-old gentleman presented with this itchy eruption on the back for a couple of weeks. So taking a closer look, you can see the primary lesion here is a papule and a pustule on an erythematous base. Whenever you see that, like this is very classic for folliculitis. And the other differential would be acne vulgaris, but unlike acne, there's no comedones. Comedones are either whiteheads or blackheads. When you see comedones, this is pathognomonic for acne. The lack of comedones suggests folliculitis as a diagnosis. Similar to impetigo, the most common etiology of folliculitis is Staph aureus. And the risk factors that result in Staph aureus folliculitis include history of atopic dermatitis, since those patients are usually colonized by staph, diabetes, applying topical steroids, occlusion, traumatizing the hair follicle by shaving can also result in staph folliculitis. There are other more rare variants of folliculitis. So whenever you encounter someone in a primary care setting with folliculitis, you can start treatment remembering that staph is the most common cause. But if it's more atypical or resistant to treatment, then you can refer them to dermatology, because there are other less common forms, especially in immune suppressed individuals, such as the herpetic form, the petrosporum. Due to the lack of time, I'm not going to go through them. So in terms of diagnosis, it can be made clinically. As I said, if you see those erythematous papule and pustule on an erythematous base, think about folliculitis. If you want to establish or determine the cause or the bacterial etiology, you can do a culture for gram stain and bacterial culture, and this can also guide antibiotic therapy. In terms of treatment, as with impetigo, if it's more localized, you treat it with topical agents. If it's more widespread, if it's recurrent, it's refractory to topical agents, or it's affecting areas with thick terminal hair like the beard, then oral antibiotic is indicated for 10 days. Think about an antibiotic that would cover the most common organism, which is staph. Such as we talked about, is either a first generation cephalosporin or dicloxacillin. If someone is MRSA carrier, think about the other agents we discussed previously. If infections are recurrent, remember you can swab the nose to see if the patient is a carrier of staph, or methicillin sensitive or methicillin resistant, and you can aim in decolonizing this patient to decrease these recurrences. So this patient was seen in the emergency for a couple of day history of this painful nodule on the thigh. On examination, it was tender as well as warm. So this is typical for, it's a typical presentation of furuncle. A furuncle usually has a central pustule that might open up, resulting in this punctum. The other differential for that is an exaggerated insect bite reaction. However, in insect bite reactions, the lesion is usually itchy, not painful or tender and warm. So what is a furuncle? Furuncle, other name, is technically an abscess around the hair follicle. And here as well, Staph aureus is the most common agent implicated. But remember, someone with multiple furuncles or recurrent furunculosis, MRSA is a common cause for furunculosis. And also in the anogenital regions, anaerobic bacteria is implicated. So how do you treat it? Like abscesses in other areas. So warm compress to aid in drainage, incision and drainage should be done actually. And if it's not amenable to incision and drainage, such as a furuncle on the face area, or someone who has cellulitis around or immune suppressed, then antibiotic therapy is indicated. And the antibiotic should cover the possibility of community acquired MRSA, as I mentioned, because it's usually a common culprit in furunculosis. So now let's shift gears and discuss this patient who presented with these painful vesicles on an erythematous base around the vermilion border. The patient notes that these lesions are recurrent, always in the same location. And this patient as well had these a more exuberant eruption affecting the medial aspect of the cheek, extending to the upper eyelid. So always recurrent in the same location. So this is a classic example of recurrent herpes simplex type 1. On the other hand, patients with primary or first episode of herpes simplex type 1 can have a more severe presentation with gingivostomatitis, lesions all around the lips and also the gingiva that can impede their ability to eat and drink. Other cutaneous manifestations of HSV1 include herpetic wetlow that can develop in children because of finger sucking, and also in adults because of digital genital contact. And finally, eczema herpeticum. What does this mean? So someone who had an eczematous lesion here, then a superimposed herpes simplex infection that rapidly disseminate. This is a case of eczema herpeticum. Those patients need treatment because of the risk of scarring associated with this condition. For HSV2, it's commonly an implicated agent in genital herpes. The genital herpes, you need to suspect it if you see lesions that are grouped, as you can see on the vulva or in the buttock area, and also on the penile glans penis or the penile shaft that can erode and result in these ulcers with scalloped borders. However, HSV1 in the last decade or so has been also commonly as a cause of genital herpes. So how do we diagnose herpes infection in general, including herpes simplex 1, 2, as well as VZV? So PCR is the most sensitive and specific method for detection of this infection from the skin or the mucous membrane. How do we do the PCR? You unroof the vesicle and you use this swab. You put it back into this like pink media and send it to virology, and you're able to identify the causative organism. Is it HSV1, 2, or VZV? On the other hand, viral culture is less sensitive, therefore it's less often used. It also can differentiate between different etiologies. DFA, the advantage of DFA is that it's very rapid. You'll usually have results within few hours. How is it done? You'll unroof the vesicle with a needle, then scrape the base of the vesicle and apply few cells into these wells. It can also differentiate between different agents, but the disadvantage is that the sensitivity is only 50% and specificity of 70%. But if you need a rapid answer, DFA would be helpful. Serology. So serology is helpful retrospectively because it needs 2 to 4 weeks. The patient needs 2 to 4 weeks for seroconversion. So it can result initially in false negative results and also can be falsely positive in someone with HSV2 infection. So when is it helpful? When someone gives you a history of recurrent lesions and you're suspecting genital herpes, you want to know, is it 1 or 2? Then serology can be helpful. Why is this important? Because people with genital HSV1 have less common outbreaks in comparison to 2. So it really affects the prognosis, and it can also determine your treatment. And the skin biopsy is of value, like it was valuable for us in our institution during the COVID pandemic because the virology lab were overwhelmed by COVID PCR. They weren't able to do the HSV or VZV PCR. So we used to do skin biopsies when we're suspecting someone with a herpetic infection, especially when the presentation is atypical. We contact the pathologist and usually have an answer within few hours. And typically in histopathology, you'll see these viral inclusion bodies that are suggestive of herpes, but you can't determine if it's 1, 2, or VZV, but the clinical context can guide you. In terms of treatment, if it's the first episode of 1 or 2, usually the presentation is very severe, so treatment is indicated for 10 days. If it's recurrent herpes labialis, topicals have a modest role. On the other hand, if someone has recurrent lesions and with prodromal symptoms of, for example, tingling or pain, you can give episodic therapy. You can tell them you can take this antiviral, one of these different regimens, immediately when you feel the prodromal symptoms, because if the vesicles erupt, then the lesions are not, then the therapy is not gonna be effective. On the other hand, recurrent genital herpes, also if they had prodromal symptoms, you can implement episodic therapy immediately with the prodromal symptoms, because otherwise, if it started after eruption of vesicles, then therapy is not gonna be helpful. When do you consider chronic suppressive therapy? Chronic suppressive therapy meaning antivirals on a daily basis. So someone who has no prodromal symptoms, someone who's really affected by the disease, someone with frequent recurrences of 6 or more, if someone has the herpes simplex that is triggering erythema multiforme with severe mucosal erosions, then think about chronic suppressive therapy. If the partner is seronegative, then yes, chronic suppressive therapy can be used, since about 70 to 90% of infections develop when someone does not have active visible skin lesions. It's because of asymptomatic viral shedding and in immune suppressed patients. So you can choose one of these antivirals that can be given daily, and then on a yearly basis, reevaluate the need for continuing treatment. You can, there was one study that evaluated the use of antivirals for at least 6 years and showed no toxic side effects, but you should reevaluate the need for that on a yearly basis. So this patient was seen by my colleague at National Guard because of these lesions that started on the scalp and progressed downwards, affecting as well the trunk area. A close look, you can see some of these vesicles are implicated. There are also pustules that you might not easily appreciate on these photos. So there's lesions of different stages. And these vesicles here that resemble a raindrop on a rose petal should trigger, should make you suspicious of primary VZV infection or chickenpox. So this is primary VZV in someone who's immune suppressed. So they're more at risk of viremia and subsequently pneumonitis, hepatitis, and nephritis. These people, these patients need intravenous acyclovir until all lesions crust. So in chickenpox, treatment for healthy children is not needed, okay? Supportive management is enough. Whereas someone who has a chronic skin, lung infection, lung disorder, someone on steroids, chronic salicylate, or someone who's 13 years or above, because of the increased risk of complications, you need to treat them with one of the antivirals for a period of 5 days. And in immune suppressed individuals, like our previous patients, IV acyclovir until all lesions crest. So a patient I saw during my my training, so with this unilateral distribution of erythematous edematous plaques studded with vesicles and impetiginized areas as well here, affecting a specific dermatome, as it's following the maxillary branch of the trigeminal nerve. So this is an example of herpes zoster or shingles. And as you can see, the importance of this case is that the patient had lesions affecting the nasal tip. So whenever you see that, though, that this area is supplied by the nasociliary branch, because of that, or the nasociliary nerve, because of that, they're at increased risk of ocular involvement. Those patients should be sent to ophthalmology to rule out eye involvement, even if asymptomatic, since uveitis can be silent. This is a patient who also was seen by me with herpes zoster affecting the ophthalmic branch of the trigeminal nerve. 50% can have ocular involvement, so consult ophthalmology when you see something like that. Any of the antivirals can be used to treat herpes zoster, usually here a higher dose in comparison to chickenpox and for a longer duration. As in chickenpox, you need to start treatment within a day to 3 days. However, in herpes zoster, studies have shown even if you start it within 7 days of eruption of lesions, treatment can also be efficacious. More importantly, also in patients who present with herpes zoster with intense pain at onset, start valacyclovir plus gabapentin, because this has been shown to decrease the risk of post-herpetic neuralgia more than valacyclovir alone. So patients seen in your clinic with this keratotic plaque on the plantar aspect of the big toe, the differential for that would be either a corn or HPV or verruca plantaris. How can you differentiate between them? You can scrape the lesion. If you see these black dots that indicate hemorrhage into the stratum corneum, this is suggestive and diagnostic of a verruca plantaris caused by HPV virus. And this is the classic textbook picture of a verruca vulgaris caused by HPV. How do we treat those patients? You can start with salicylic acid preparation, since evidence have shown an equal efficacy to cryotherapy and resolution of lesions in almost 2/3 of treated patients. However, patients should be compliant on that daily for 3 months. How do you treat them? You ask them to apply the treatment on the wart and Vaseline around the wart, apply, occlude the area with a tape and change the tape every 2 days. You can, and every few days, you can pair the skin using a nail filer after soaking in warm water. If you feel that the patient has multiple lesions, they might not be compliant to on home salicylic acid, you can refer them to dermatology for cryotherapy. This is usually done every 4 to 6 weeks. And we also have different other treatments in resistant and refractory cases. Okay. On the other hand, a genital HPV or condyloma acuminata, the patient should know that regardless of the treatment modality, 50% of patients would have recurrent lesions. Why is that? Because a lot of lesions are subclinical and might not be targeted by treatment, so HPV would recur. And treatment is divided into either patient-applied or office-based. You can combine both together. You can start them when you're seen in a primary care setting on imiquimod 3 times weekly for a max of 16 weeks. Podophyllitoxin is used in North America. It's not available here. And you can, if you feel that the lesions are multiple, if they're affecting the patient, or you want to decrease the risk of transmission to the partner, although it's controversial if treatment decreases the risk, you can also refer them to dermatology for cryotherapy, a TCA, it's a chemical peel, electrocautery, surgery, and also laser therapy can be done. In pregnancy, it's safe to use cryotherapy, TCA, surgery, and as well as laser. So this patient I've seen this patient in the inpatient setting for this rash that looked, as you can see, these are annular plaques with central clearing and erythematous scaly borders. Whenever you see this morphology, think about dermatophytic infection or tinea. So what did I do? Scraping. So you scrape the edge, okay, and you put KOH. If you have a microscope, you can look at it under the microscopy in clinic. And you can see these hyphae that are branching at 45 degrees. This is pathognomonic for dermatophyte or tinea infection. This is tinea corporis. Corporis is the Latin name of the involved body part, meaning that there is involvement of areas that are devoid of hair, or like a glabrous skin. Okay. On the other hand, this is an example of tinea pedis, and this is the more classic example of tinea pedis affecting the interdigital web spaces. There's different types of tinea. Due to the limited time available, I'll only address these. This is an example of tinea capitis. Tinea capitis usually presents with non-scarring hair loss. Sometimes the base can be non-scaly or scaly, or can have an exuberant reaction, like in this patient with a carry-on. So how do you, before treatment, so how do you diagnose those patients? So quickly, so you can scrape the scales and put these scales in a Petri dish, send it to microbiology, then a KOH and fungal culture can be done. In terms of hair, you can do the same thing, or you can use, on the other hand, a culturette, so a bacterial culture, and the swab moistened with the bacterial medium, and then you can rub it on the affected area. And this study have shown an equal efficacy in detection of tinea infection and of tinea capitis with a culturette and scraping. On the other hand, nails, you can send a specimen of nail for a fungal culture, but the sensitivity is only 30 to 60%. Because of that, we usually take another clip of another nail, a piece, and send it in formalin to histopathology to increase the sensitivity to almost 95%. So how do we treat these patients? Usually topical antifungals. You need to start either terbinafine or one of the azole antifungals, such as clotrimazole and miconazole, not nystatin, which is typically effective in candidal infection. When do you start oral? In patients with tinea manum, or because of the thick stratum corneum, so tinea infection of the hand or the palm, as well as tinea capitis because of involvement of terminal hair, unguium affecting the nail plate, and extensive tinea. What are you going to choose? Either terbinafine, itraconazole, fluconazole, and griseofulvin in pediatric tinea capitis. In our final case, so this 6-year-old boy presented with significant scalp itching, and as you can see, those impetiginized erosions affecting the occipital scalp, the nape of the neck, and behind the ear area. Whenever you see that, think about head lice or pedunculosis capitis. You examine the hair, you can see those tightly adherent nets to the hair. It's very difficult for you to move them away, unlike scales associated with seborrheic dermatitis. So head lice, there are different treatment modalities. Dimethicone is commonly, or the other trade name of it is NIDA, is commonly used in Saudi Arabia and Europe because it's a safe silicone oil with no adverse events, and also it has good efficacy. Whatever treatment you're gonna choose, you need 2 applications separated by a week. Why is that? Because some eggs can escape the first application, so you want to target it with the second application. And regardless of the treatment, you'll also advise the parents to wash clothes and linens in a hot temperature, or dry it in a high temperature. All the clothing and linens, bed linens used 2 days prior to this application. Other than dimethicone, permethrin cream can be used. However, it has a fair efficacy. Benzyl alcohol and spinosad has good efficacy, but I'm not sure if it's available in Saudi Arabia. Malathion is not available here. It's used in US, but it's only used in children who are more than 6 years of age. And finally, ivermectin orally can be given in someone with refractory head lice, but it's contraindicated in someone who is less than 15 kilograms because of the risk of neurotoxicity. And finally, given that we're in during the COVID pandemic, I'll discuss about COVID and the skin. So now we know that almost 20% of COVID patients can have cutaneous associations, and there are 5 different subtypes of or 5 different morphologies associated. These can aid in early diagnosis as well as can help in prognosticating patients. So the most most characteristic skin lesion is acral ischemic lesions, as you can see here, or what they call also COVID toes. This present late during the course of the illness, and usually patients have a mild clinical phenotype. On the other hand, someone who has these vesicular lesions or chickenpox-like lesions, usually this presents early on, either with other symptoms, or in 15% of cases, it even predates other symptoms. So you can, if you see someone with that, like you can screen them for COVID and detect them early. Usually those patients have a moderate disease. Urticarial rash also develops early during the course of illness, even sometimes before other symptoms. So if you see someone with acute urticaria for the first time, think about COVID. And usually severity here is variable based on the literature. Some patients have more mild, moderate, or severe disease with a mortality rate of 2% established in association with urticarial rash and COVID. Maculopapular is actually the most common morphology associated with COVID. Accounting for almost 50% of cases. Usually it accompanies other symptoms or can develop later. Usually those patients also have severe clinical phenotype, a severe clinical phenotype with almost 10% mortality rate reported in association. And finally, the livedoid pattern that also, like maculopapular eruption, accompanies symptoms or develops later on. And the prognosis associated with this subtype is not well defined yet. And with this, I conclude my talk. Thank you for listening, and I would be happy to answer any of your questions.
Thank you so much, Dr. Abia, for this informative lecture. We have some time on us to run some questions. Our first question is, what's the difference between erythrasma and non-bullous impetigo?
Okay, so non-bullous impetigo, the organism implicated is staph, whereas in erythrasma is non-diphtheria corynebacterium, okay? And the other difference is that non-bullous impetigo classically is periorificial. You can see honey-colored crusting. You treat them with staph aureus specific treatment, whereas erythrasma classically affect flexors and can have, so it's flexors, okay? It looks like a scaly erythematous plaque, and then you can use a Woods lamp that would show you a coral red color. And then you're going to be like, this is okay, more likely corynebacterium related. And treatment is usually with macrolides like erythromycin, unlike with non-bullous impetigo, in which treatment is with cephalosporin and dicloxacillin, or with the topicals we discussed.
Great. If cephalosporin and doxycycline is not available, what can we use for impetigo?
Okay, as I mentioned, so if impetigo lesions are focal and localized, you don't need oral antibiotics. You can give fusidic acid or mupirocin topically. On the other hand, if it's more extensive, you want to try an oral antibiotic. So a different first generation cephalosporin like cefadroxil, for example, the encephalexin is what I talked about. And you can also, the dicloxacillin, otherwise erythromycin, azithromycin, clindamycin, all of these agents. Most importantly, something that would cover staph and a group A strep, if it's non-bullous impetigo. Yeah.
Great. And is there a way to diagnose staph colonization by history purely?
So if someone has recurrent lesions, think about that. What you can do is like taking, you can do a nasal swab for staph carriage, and you can see is that because 30% of individuals are carriers for staph, especially someone who's hospitalized or a healthcare worker. So you can do a nasal swab and it would tell you if someone is a carrier of methicillin sensitive or methicillin resistant staph.
Perfect. And should we use acyclovir for a patient who has chickenpox or eczema?
chickenpox or eczema. So chickenpox, you can use acyclovir or valacyclovir. Both of them are FDA approved. For eczema herpeticum, meaning maybe eczema with superimposed HSV1, not VZV. Also here, you need to give antivirals, either oral or IV. So if it's oral, then you can, acyclovir can be given. If it's IV, the only IV available is acyclovir, especially IV in someone who has systemic symptoms. So fever, they look unwell. So it's different. So eczema herpeticum is caused by HSV1, whereas VZV, chickenpox, but both of them, you can use acyclovir. And as I mentioned, the different oral versus IV.
Perfect. Should children with head lice stop from going to school, or they can just attend regularly?
Guidelines suggest that they can attend regularly because they actually might have like the symptoms, or like they're infected a couple of weeks before establishing the diagnosis. So there's no value of locking them at home, but you would instruct teachers at school to decrease maybe like head-to-head contact and not use some fomites or not share some fomites between the infected person and other students, but they can go to the school. They don't need to stay at home.
Perfect. And someone's asking about Piadra. Can you give a definition to that, please?
Piadra, okay. So Piadra is a different type of superficial fungal infection. So it's either white or black, depending on the organism. And usually it affects areas, hairy areas such as the axilla or sometimes the groin. So it looks different. And the first treatment for that is really shaving areas that are hairy, such as the axilla and the groin, with or without a topical treatment.
Perfect. Should a patient with herpes labialis be treated, or they can be left untreated?
They can be left untreated, but if there is impetigo, because we said impetigo can be secondary, so an eroded area is at risk of secondary bacterial infection, then you can give a topical fusidic acid or mupirocin, depending on sensitivity. But if someone is really bothered by it, like and having recurrences that are 6 or more, and it's really affecting them, so yes, then treatment is indicated, and you can start the episodic treatment if someone has prodromal symptoms, because it's not effective if vesicles erupt. If someone has no prodromal symptoms, they're really affected by it, they have more than 6 attacks, you can give them chronic suppressive therapy.
Perfect. I believe we answered the majority of questions, as the rest are being repeated. Thank you so much for your time and this highly informative lecture, Dr. Abir Sarhid.
Thank you so much.
Dear attendees, thank you so much for being with us today. It's been a true pleasure having you with us. With that, we conclude our sessions for today. Please be sure to check our Twitter account for the link of YouTube in case you can't log into the Zoom room, and register to make sure you receive your CME hours. Thank you so much again for attending. We look forward to seeing you tomorrow, same time, 4 to 8. Have a wonderful evening.